inaugural function of workshop on preparation of patients on safe evacuation, we are honored by the presence of esteemed dignitaries who have gathered here to inaugurate and share valuable insights during this special occasion. We now request everyone to warmly welcome our chief guest, Sri Vivek Srivastava, IPS, Director General of Fire Services, Civil Defense and Home Guard, along with the distinguished dignitaries, Dr. Prasant P. Joshi, Executive Director, AIMS Nagpur, Sri N.B. Singhne, Director, NFSC, Sri Prasant Lonkar, Fire Advisor, Director General Fire Services, Civil Defense and Home Guards, Sri Sasikant Sambarkar, Deputy Director Public Health, Government of Maharashtra, Nagpur, Dr. Deepak Salokar, Chief Medical Officer, AMC Nagpur, and Dr. Avinash Gawande, Medical Superintendent, GMC Nagpur.
Now it is time to extend a, now it is time to extend a floral welcome to our dignitaries as a token of our respect and gratitude. I request Shri N.B. Shingne, Director NFSC, to offer a flower bouquet to Shri Vivek Srivastava. I would like to call Dr. Prashant P. Joshi for floral welcome by Director NFSC. Now I invite Professor Dr. A.R. Sontake to kindly offer flower bouquet to Dr. Shashikant Shambarkar. I would like to call Shri Prashant Lonkar for floral welcome by Dr. A.R. Sontake. Now I invite Colonel Nikhil Pandey to kindly offer flower bouquet to Dr. Deepak Silokar. I would like to call Dr. Avinash Kavande for floral welcome by Colonel Nikhil Pandey.
At NFSC, safety is our paramount importance. Let us now take a moment for a brief safety orientation to ensure that we are all well prepared for any eventuality.
कृपया ध्यान दें, यदि आप आग या धुआं देखते हैं तो तुरंत अपने निकट मैनुअल कॉल पॉइंट दबाकर या आग आग बोलकर दूसरों को सचेत करें। फायर अलार्म या अग्निशमन विभाग टीम के सदस्यों की आवाज सुनकर निकटतम सुरक्षित एग्जिट द्वारा तुरंत सभागार से निकले और असेंबली पॉइंट की तरफ जाइए। सुरक्षित निकास के लिए बिना घबराए इसका पालन करें। इमरजेंसी एग्जिट के दौरान मैं किसी को धक्का नहीं। सभागार के पूर्व और पश्चिम ओर असेंबली पॉइंट है। पश्चिम ओर की असेंबली पॉइंट मार्टर्स कॉलम के पास है। आपातकालीन असेंबली पॉइंट में सभी इकट्ठा हो और अग्निशमन विभाग द्वारा निर्देश की प्रतीक्षा करें। आज कोई सुरक्षा ड्रिल आयोजित नहीं की जाएगी, अतः फायर होने के संकेत पर अब भी बताई गई अग्नि सुरक्षा प्रक्रिया का पालन करें। याद रखें, जागरूकता ही आपकी सुरक्षा की दिशा में पहला कदम है। ध्यान देने के लिए धन्यवाद।
Now, to mark this auspicious beginning of the program, we will now have the ceremonial lighting of the lamp. I invite our dignitaries to come forward for the lamp lighting ceremony, accompanied by the soulful recital of Saraswati Mantra.
तेतु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा। शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीम्।
I now request the Director NFSC Nagpur to formally welcome our distinguished guest and share a few words with us.
Good afternoon all. Our patron Sri Vivek Srivastava ji, IPS, DG Fire Service, Civil Defence and Home Guard. Dr. Prashant P. Joshi, Executive Director, All India Institute of Medical Science, Nagpur. Dr. Avinash Gaunde, Medical Superintendent, Government Medical College, Nagpur. Dr. Shashikant Sambarkar, Deputy Director, Health, Government of Maharashtra, Nagpur. Dr. Deepak Selokar, Chief Medical Officer, Nagpur Municipal Corporation. Teams from the Lata Mangeshkar Hospital, Care Hospital, our RTCs and training officers, RTCs online, and all the training officers. It's our privilege to have today the workshop in partnership with the All India Institute of Medical Science, Nagpur. After joining as a director at this institute, while discussing the challenges before fire services with our patron DG Fire Services, hospital fires emerged as a major issue, and I was convinced that the fire safety at the hospital is at the very high priority at the highest level in government. And when India is poised for the fast developing economy, health for the everyone, and safety, fire safety is a very important thing. Our team, inspired by the concerns of the ministry, in collaboration with the ED, All India Institute of Medical Science, and in association with the National Cancer Institute, Lata Mangeshkar Institute, and Government Medical College, Nagpur, to plan this half-day session, brainstorming session on very important parameters at the hospital fire safety. You know, in case of any disasters, hospitals are the center of relief. Everybody runs towards the hospital for the safety and health. But when it occurs at the hospital, then the scenario is a very worrisome. So in this case, evacuation of the hospitals is not like any other occupancy for the firefighters. You take example of any other occupancy, industrial occupancy, public occupancy, markets, that is a different kind of or quite similar type of the evacuation strategy we can adopt. But when it is a matter of concern at the hospital, then there are very serious limitations for the safety evacuation. So even the casualties there, they may require, especially life supports are required, prioritizing required. There should be will require to have the collaboration with the nearby medical facility, because the hospitals they can only decide which patients and what way they can be prepared and they can be made ready for the evacuation. If they are made ready for evacuation in time, then many of the hospital fires, our survival rate will be very, very high, or sometimes it can be brought to the minimum level also. So on behalf of my team NFSC, I welcome all dignitaries present on the dais and the teams from the doctors and all presenting officers. Very special presentations of the eminent and very experienced medical professionals of the AIMS, NCI, Lata Mangeshkar Hospital, Care Hospital will help us in formulating the guidelines which can be standardized at the national level for the various types of the hospital and sanitarium for minimizing the loss to the human life during the fire incident. Once again, I welcome you all on behalf of Team NFSC. Thank you.
I request Dr. Avinash Gawande, Medical Superintendent, Government Medical College, to deliver his insightful words.
Good afternoon all. Respected dignitaries on the dais, Honorable Srivastav sir, Honorable Executive Director AIMS, Dr. Prashant Joshi sir, who happens to be a mentor of most of the medical graduates from GMC Nagpur, Director of this college, Singhne sir, Fire Advisor, Sri Lonkar Sahib, the Deputy Director of this region, my friend Dr. Shashikant Shambarkar, Chief Medical Officer of NMC, who work with me during COVID period, Dr. Deepak Selokar, dignitaries present in the audience, all colonels and teaching staff of this college, all the participants, and galaxy of speakers. Some of them I know, Dr. Nishan Banai from AIMS, Dr. Sanjay Deshmukh from Daga, Dr. Mayank from GMC, and all the participants. Really, as a medical superintendent, we all from medical colleges, all administrators are on the fire daily. Day before yesterday, I was in the meeting of fire audit in GMC Nagpur. In that meeting, I utter one word. आप लकी है, अभी तक GMC में बड़ी मेजर फायर नहीं लगी है और होपफुली लास्ट आगे 25 साल भी नहीं होंगी, लेकिन it can happen today evening only. Thanks to this director of this college, because it is one of the important topic, and we are, I think, in the KG1 or in the primary schooling of this topic. Because you all knows, nowadays this modern era, this topic is most important and burning topic. Because of modernization of the all hospitals,
there are newer techniques, newer machineries, and there is higher chances of fire in the hospital. And in this case, the important thing is all the persons from hospital, maybe medics, that is from faculties, or resident doctors, maybe paramedics, the nurses and class 4 workers, or even social security, social person or security person from college. They should be equally, they should have the idea of regarding this fire safety and evacuation process as far as medical college is concerned. Because I think that the fire is such a topic, it requires so many things. Rescue of the patient, rescue of the person who are at the what you call it, in danger of the life, then that is activating the alarm, then containment of the fire, and if required, in evacuation process. These are the important processes that should be known to each and every from the medical college. And I think this type of workshops should be there. This is the need of hour. And all through this galaxy of speaker, you will be benefited. You will be this workshop should be like a training of trainers, and you can train your subordinate, your respective medical college. Thank you so much for inviting me. Thank you all. Jai Hind, Jai Maharashtra.
It's my privilege to invite Professor Joshi, Executive Director of AIMS Nagpur, to deliver the keynote address.
Good afternoon to all of you. Respected dignitaries on the dais, we have Mr. Vivek Srivastav, who is IPS officer and director. Then the director of this institute, Shingni. We have my friend over here, Avinash, who is the Kavande, who is the medical superintendent. Then Dr. Lonkar. Then we have Dr. Senokar, who is the district professor previously, and we had been in contact, especially during COVID times. And Dr. Shambarkar, who is newly joined as a director, as the deputy director of health services here in this region. And the other dignitaries of the dais. Right at the outset, let me congratulate NFSC, National Fire Safety College, and Dr. Shinde's person for taking all the initiative to organize this very important program for our symposium to sensitize all the people to be prepared of patients for safe evacuation. Now that's a very important topic from hospitals and doctors' point of view. And the code which is used medically whenever there is a suspected or there is a fire outbreak is what is called the code red. And fortunately, there are fire alarms available now. There are certain norms which needs to be followed. And as soon as the fire alarms burst, the whole system should get activated. Recently, we have Nikhil Pandey here, who is the superintendent engineer at AIMS here, who is looking after this fire safety. And just quote as incident a few days back, there was a fire in the basement. Essentially, because in the basement there was dumping of some general waste, and somebody put either a cigarette or I do not know how it got. But fortunately, because the fire alarms and the system was working, and in the preliminary stage, everyone was activated, and absolutely no damage was done. So this indicates the alertness with which we need to be prepared. Now, fire safety in hospitals. In hospitals, there are patients. In intensive care, especially, patients are on ventilators. Patients cannot by themselves go out. They have IV fluids going on. They have catheters in place. It's impossible for these patients to get evacuated or to mobilize and to go away, or to if there is a fire, to get out from that room. It's impossible. And therefore it is very important that we have all the preventive measures in place. Now we have 4 speakers today from AIMS. We have Dr. Narang, who is in charge of medical intensive care. We have Abhijit Chaudhary, who is in charge of pediatric intensive care. Then we have Dr. Nishant Pranayat, who is in charge of neonatal intensive care. And we have Dr. Sucheta Bhatti, who is in charge of the surgical intensive care. And they will be delivering talks here about on this further topic, and would enlighten all of you on this, and then how we need to be prepared to in case of an emergency which could come any time in the in the odd hours of the night. We should all be prepared. In fact, because intensive care setting, in fact, is a situation where a lot of electricity is needed. There's so many ventilators going on. It's always air conditioned, and there are other equipments which are on which need which consume a lot of energy, electricity. It's possible because of short circuit or because of any reason, fire can is prone for overload and short circuits, which can trigger fires. And therefore it is very important that fire audits be performed. We have been performing, and in fact we have seen such instances. There was a big fire outbreak in Kolkata Hospital, private corporate hospital, a few years back. I remember that. And recently in Delhi, near Delhi, there was again an important fire outbreak in the neonatal intensive care. A lot of people, there were some deaths due to that. These are totally preventable, and in fact, fire audit is necessary. And whenever an intensive care or a hospital is built, fire clearance is a necessity, and all the guidelines are in place. And these need to be followed, otherwise you are not able to open the hospital. And therefore, these need to be followed. At AIMS, Mr. Nikhil Pandey is always conducting fire drills. Every 6 months, we had it recently, about 2 or 3 months back, where the whole process, a mock drill was conducted of how patients from the 3rd floor, 4th floor, without using the lifts, because lifts are not to be used when there is a fire outbreak, how they would be they will get evacuated, and how they will be brought out, and how to use, and training the staff of how to use a fire extinguisher. Many of us see that fire extinguisher, but the person who is very most near to that fire extinguisher when the fire breaks out is the person who needs to use that. He should be, so it is, you cannot predict who would need it, and therefore it is essential that everyone, right from the class 4 to class 1 officers, should be trained to use all these equipments, fire equipments and fire dousing equipments. That has been done in the fire drills, need to be conducted, and all the people, and when I say all the people, I mean all the people, means right from the lower to the upper people. All the people should be trained of how to do, what to do if there is a fire outbreak, and how to evacuate the patients effectively and swiftly without going into panic is something which needs to be learned, and which needs to be practiced. Patients are in the intensive care, and there is a big fire. In that situation, you can imagine the difficulty with which patients have to be evacuated, and with minimal injury and minimal damage to the visible casualties is something which is very essential that we all know this procedure very at the tip of our fingers, all of us, because we don't know when this emergency would come. So it's a very sensitive topic and on this, and again I would like to congratulate the National Fire Safety College and especially Dr. Shingle for organizing this symposium of half day or workshop of half day where deliberations and interactions and would occur about how to keep safe and what to do if there is a fire. Thank you very much for inviting us, and it's great to collaborate with NSFC, and we at NAMS are always ready to collaborate on this important issue. And it's a norm, it's a necessity, it is mandatory as per law that we have these kind of workshops. Not only that, we have all the drills and mock drills are in place. We have all the national safety, this fire safety measures in place, and we should be very sure that we are doing the right thing so that we are able to save lives. Thank you very much for calling me.
We are deeply honored to have Sri Vivek Srivastava, IPS, with us today. I now request him to deliver the inaugural address.
Good afternoon, everybody. Dr. Prashant Joshi, Executive Director at AIMS, Nagpur. Shri Shikane, Director, NFSC. Shri Dr. Shashikant Shambarkar, Deputy Director, Public Health Department. Dr. Avinash, MS, GMC, Nagpur. Prashant Rotkar, Fire Advisor. Dr. Deepak, Medical Health Officer. Students of NFSC, my dear friends. This is actually indeed a very important topic. And so, although it is the post-lunch session, I would request all of you who are in a preparatory stage of dosing to actually become slightly more alert. These hospital fires have taken place with quite a regularity in India, and it has actually come to notice at the highest level, of the level of the Prime Minister of this country. And he had expressed his apprehension that we should actually do something to mitigate these incidents, especially in hospitals and even in schools. I take this opportunity to thank Executive Director AIMS of agreeing to collaborate with Director NFSC to have this symposium. And I also extend my gratitude to all the medical professionals who have been here, who would be contributing towards formulating a SOP so that we can deal with hospital fires in a more effective and a proactive manner in the future. I would also like to assure all of you that whatever is the outcome from this conference, half-a-day conference, we would be taking back. And I have had a discussion with the member NDMA also. He was also very interested in knowing that such a conference is being organized. And he has actually personally requested me to give the outcome of this conference so that we can actually disseminate whatever comes out of it to actually across the country. And the first we will be doing, once this is concluded in January, with the cooperation of the Delhi Fire Chief, who is actually sitting here in Delhi itself, where we will be calling all the persons who are looking after the administration and the fire safety of all the hospitals and nursing homes in Delhi. So we will be organizing a pretty largest conference on that. So this is a very important preparatory step before we organize this conference in Delhi. The next step which we collaboration with the Ministry of Health, and then after roping in the Ministry of Health to organize such sensitization and actually educative sessions in every state of the country so that hospital safety is given priority, especially with regard to fire. Now, unfortunately, hospitals are also places where this fire occurs very frequently. In fact, a survey was done in the United States, and the outcome was that almost 10% of all fires which take place in the USA, which actually happens in hospitals. Hospitals are also a place where these kind of fires can do actually very serious damage because, as you all of you are aware, these are the places where people are not in their best of health. Many in the ICUs actually are on life support system, so it becomes actually very difficult how to actually evacuate a person who is himself in life support. As Dr. Joshi was himself mentioning, unless the medical profession and the fire services they collaborate, they can't actually agree on a modus vivendi on what should be the procedure of evacuating actually a patient who are themselves on life support. So the very process of evacuation may actually lead to death. So there has to be a combining of the inputs from both the medical fraternity as well as from the fire fraternity to come to a conclusion to what should be the standardized SOP across India. Now there are a number of causes for hospital fires. I will list a few of them. Maybe just all of you would be aware, but just for you. One of the most common reasons for fire in hospitals are actually electrical based. This is because of a number of reasons. Many hospitals and nursing homes are there which are existing since maybe 50 years, 75 years. This GNM, I'm told, is actually a 75-year-old hospital. So all the electric fittings, etc., would have been made, and of course it might be refreshed year after year, but there is always a time gap. So while equipments get added, new and new hospital equipments come, new and new life support equipment comes, all of these equipment are actually energy intensive. While the capacity to provide that energy by the electrical systems, that may remain the same. It might not keep pace. So actually, we actually miss out. While we may add a air conditioning system, two air conditioning systems, where as the financial health of the hospital improves or the funding improves, there may not be a commensurate effort to upgrade the electrical systems to take that load. So that is because one of the more common sources for electrical fires is the electrical equipment. The second is the kitchen facilities. That is also one area where flammable things are there. The gas is there, even ghee is there. All of them are combustible materials, so that is another area. Again, as Dr. Joshi was mentioning, in the basement, the cigarette may have been there. So cigarette is also a very common source where people actually casually they throw away the cigarette butt, and it may lead. So hospitals should be very scrupulously. They should follow a no cigarette rule, not only because it is injurious to health, but it is a source of fire. Specialized medical equipment, as I have mentioned, is becoming increasingly getting used, which consume power, and there should not be a mismatch regarding those. Hand sanitizers we have been started using in a big way, especially after COVID. Now, as all of you know, is hand sanitizers primarily it is alcohol, and alcohol is a very flammable substance. So use and indiscriminate use of hand sanitizers also has its consequences by increasing the fire load in that area and gas cylinders and medical oxygen compliance requirement, that also increases the vulnerability to those areas for fire. For example, in the ICU, I was actually speaking regarding that incident in a hospital which happened in UP, where many patients died. So while I was speaking to the DG Fire Services of UP, he said that it was very difficult for the firefighters to douse the fire in the ICU. And what they suspected was that because there were many patients on life support and oxygen, there was a lot of the oxygen content in the air, the ambient air will have a penalty as far as increasing the capacity of the fire to spread there. So ICUs, because of the higher, because while the oxygen is being given, it will be leaking. So it is very likely that the oxygen content in the ICUs will be much higher than the 20-21% as we normally do now. Anesthesia machines are also a source of fire, and these are life again because of the higher oxygen concentration which they produce. We, as I said, as number of equipment gets added, the number of switchboards remain the same. So what do? We have extension cords which have actually 3, 4, 5. So this daisy chains, these extension cords are a great source of fire because one, they may not be standardized ISI switches which are actually booked because if it is a PWD, they are enjoined to put ISI marked switches there. But for extension cords, there is no such stipulation. You go to the market, you buy extension cords. So that is also one another very. Next comes fire training, which we hopefully will address during these sessions. Improper storage of combustible material because a lot of plastics are there for gloves,
With that inspiring address, we conclude the inaugural session. I now request all the dignitaries and participants to proceed for a group photograph, followed by high tea. Kindly reassemble here after 20 minutes for the technical sessions.
The panel members to chair these technical sessions. In the first sessions, I would like to invite our Honorable Director General Sri Vivek Srivastava sir, IPS, Sri NB Shingne sir, Director NFSC, Dr. Deepak Selokar, Medical Health Officer NMC, and Sri Atul Garg sir, Director Delhi Fire Service. Sir, we invite you to sit on the dais to chair the technical session. Let's begin the technical sessions. In the first session, the theme is the fire prevention and patients evacuation strategies for critical care units. In these first technical sessions, the eminent experts, Dr. Suchita Bohate, I welcome Dr. Suchita Bohate from AIMS Nagpur, Dr. Udit Narang, Medical Intensive Care Unit, Dr. Abhijit Chaudhary, Pediatric Intensive Care Unit, Dr. Nishant Banayat. So these four people, and from the first part of the session, Dr. Suchita Bohate ma'am will address the first technical session.
Good afternoon all. Myself Dr. Sucheta Meshram. I am an associate professor and surgical ICU in charge at AIMS Nagpur. Friends, when we talk about fire, it has a huge spectrum. At one point, fire we worship as a source of illumination. Illumination. At the another end, when the fire shows furious a kind of execution, then we are afraid and apprehensive of it. So we have to define a strategy wherein we can tackle this hazard in the best possible way. So we are here as a part of fire safety campaign. I'll be talking about the guidelines for preventive measures. So fire disaster from the historical pages. In the history witnesses very tragic events in past, that is in 2008, when in Royal Marsden Hospital, London, thereafter in Royal United Hospital, Bath, and Royal Stoke University Hospital, the ICUs were set in fire, and the people have encountered a very difficult situation. Hence, guidelines were formulated in order to tackle the fire tragedies in a well-defined manner. Not only the world outside, but also in India, frequently we encounter such news that the fire outbreak has taken place in various corners of the country. And it left us with a very devastating state of affairs to how to tackle it and prevent it. Why the ICUs are so vulnerable for fire outbreak? ICUs are potential for disaster which is substantial. An increase in oxygen concentration results in more rapid and intense combustion, which facilitates the fire dynamics. The fire increases the thermal intensity. ICU being closed space structure is added challenge for the rescue strategy. Herein, the patients are bedridden, unconscious, ventilator dependent, with multiple plugged medical devices and very difficult to move. The ICU is vulnerable not only for the patients who are dependent, but also they are a potential risk for the staff. Short circuit fire is the commonest form of fire which is being encountered in the ICU setups. This short circuit is a double-edged sword, because if the circuit is tripped by virtue of fire outbreak, there will be all darkness. We assume that in fire outbreak everything will be normal, but it is not so. The first thing which will happen with the circuit trip is all darkness, and we will be in a state of chaos and confusion. The electrical overloading and faulty wiring leading causes of electrical fires, and there will be machinery breakdown. As we all know that the patients in ICU mostly are on ventilators or on certain infusion pumps, or they are having certain medical devices which will be ongoing requirement for electrical supply. So if this electrical supply is cut down, there will be total machinery breakdown. The another aspect is, if this circuit is not tripped, that is a natural course of action that this circuit has to trip. If this circuit is not tripped, then there is threat of electrocution with water sprinkler, because subsequently we intend that the sprinkler will be in action. But if this circuit is not tripped and water is sprinkled over it, that will be a threat for the one who will be extinguishing this fire with the sprinklers. Coming to a situation why a circuit breaker does not trip even when a wire is on fire or burning. So there are various reasons underneath, like undersized or incorrectly rated circuit breaker, poor connection or loose wires, overloaded circuit, faulty circuit. As Srivastav sir has very well explored that when you use multiple wires or cables at one point, then it is vulnerable for the short circuit. So this is one of the reasons. Environmental factors, arc faults, ground faults, deteriorated insulation or delayed response are the other possible causes when the circuit is not tripped in a natural course of action. So the first thing to ensure that the circuit is tripped or not. If the circuit is not tripped, you are supposed to manually trip it so that the electric continuity will be broken down and the threat of electrocution is prevented. So in a scenario of fire outbreak, there will be all darkness. There are multiple entities we will be dealing at one point of time. There will be all dark, confusion, chaos, uncertainty, apprehension, and disappointment. In state of such despair and disappointment, you have to deal effectively. So darkness is one of the important threat when we talk about ICU fire outbreak. And the another most vulnerable thing is smoke. Why we are so much apprehensive about smoke? Because the fire smoke is comprising of carbon monoxide. This carbon monoxide is highly hazardous gas. This is hazardous because it adheres with the hemoglobin and it has more affinity, more attractive forces toward hemoglobin. Approximately 200 times more affinity than oxygen. So this carbon monoxide will be binding with the oxygen in a more fixed manner, and that will cause the oxygen dissociation curve to shift leftwise. This means, to simplify this, it means that at the tissue level, the release will be impaired. There won't be the release of oxygen at tissue level. And we all know that oxygen is the most important gas required. As we say that pranvayu. So if the oxygen is not delivered at tissue level, the tissue will undergo hypoxia and its sequelae. So smoke is one of the most dangerous entity. Another threat with smoke is the smoke will cause mental confusion and difficulty in consciousness. It will make the is it audible? Yeah. So I was talking about carbon monoxide. So the smoke is comprising of carbon monoxide, and because of high affinity, the release of oxygen at tissue level will be impaired, causing hypoxia. Hypoxia means deficiency of oxygen at tissue level. This will also cause the loss of consciousness. There will be confusion and ultimately patient will collapse. So it may not be the direct thermal injury because of fire, but because of this unconsciousness, the act of excavating himself or for the patient will be jeopardized. So this is one of the biggest threat as far as smoke is concerned. Another part of fire smoke is hydrogen cyanide. This gas is also a very potentially hazardous gas, and the toxicity of hydrogen cyanide is 30 times more than that of carbon monoxide. So we can imagine the threat of smoke when we are talking about the fire smoke hazard. So smoke is very challenging entity to deal with. Not only the flames, but we also need to think about the darkness and the smoke, which are equally deleterious for excavation purpose. So what are the remedial therapies or remedial solutions for this? So there is an automatic emergency low-level lightning system. Smoke can significantly reduce visibility, not only for the inhalational toxicity, it also impairs the visibility in the event of fire. And this can hamper an emergency evacuation. So low-level emergency lighting should be installed when ICUs are or operating theater suites are built. So while designing the operation theater or intensive care unit, we have to think about this aspect, and we have to install this automatic energy low level lightning system, which will automatically illuminate and will guide the road towards safety. So that is an important aspect. Another aspect is the fire alarm systems, which automatically trigger emergency low level lighting is imperative. This is inbuilt phenomena. So once the alarm is activated, automatically the low level lightning system will be illuminated and will show the safety passage to all the victims. Fire smoke detection alarm. When a fire system is activated, a signal is sent to an alarm receiving, it is alarm receiving center, wherein they will recognize where exactly this fire outbreak has taken place, and they will immediately activate the team or the disaster management team, which is to be well defined before in place. So this team will not only alarm or activate the concerned area, but also the area in vicinity, which is also a potential danger. Most of the time, a false sense of safety is deceptive. We feel that we are safe. The fire outbreak has taken place nearby. It is not going to affect us, but this is a false impression. So all the areas in vicinity of fire outbreak should be alarmed, so that they will be aware enough and they will be in a position to tackle it more effectively. So not only the area which is being affected, but the area of in vicinity has to be also activated and should be alarmed. Staff also responds better not only to audible but also visual alarm. So both the alarms should be incorporated so as to attract the attention and to activate the team promptly. In regards of this fire outbreak, as I have narrated, is my first opening slides about the tragic events occurred across the globe. An association of anesthesiologists and intensive care of United Kingdom has drafted a policy directives defining the guidelines how to tackle the fire outbreak and how to evacuate the patient effectively and safely so as to prevent the casualties and mortality. This was published in the Journal of Anesthesia in May 2021, and these guidelines are followed across the globe to prevent the fire casualties after fire outbreak. So what are the guidelines are talking about? These guidelines implied that there should be an NOC before establishing any hospital for that matter. They have to follow the all rules and regulation in order to get the certification for establishment of any hospital. So all these rules and regulations and government policies are to be incorporated, all do's and don'ts are incorporated, and timely audit is to be ensured. These are all the parts of certificates. So once you start, an hospital is being to start with, this no objection certificate from the regulatory bodies is a mandate. Furthermore, the design of standards ICU are being defined in the journal as I have told in my previous slides. This article has standardized how should the design of ICU should be. It mandates to incorporate the fire safety features in the architectural plan itself, and there should be an essential ramp system, which is the commonest thing which is being forgotten when the architectural plan or layout is designed. So this is very important. The ramp system is to be incorporated whenever a hospital or an ICU is being designed. The ground floor location is an ideal location which is recommended, and it should be there should be interconnecting routes with operation theatre suites to facilitate evacuation, smoke control systems, and misting fire suppression systems. So it should be preferably on the ground floor, and there should be having multiple exits when we are planning any hospital or ICU for that matter. If the ground floor is not practically feasible, then it is being recommended that the evacuation lifts should be well maintained, and they should have dual electrical supply, which will be helpful while rescuing the staff or the patients. They have also recommended about ICU pendants. These ICU pendants, they are effective environmental devices. They deliver safe and more ergonomic, streamlined access to medical equipments and gases. And the hazards can be minimized with the usage of ICU pendants. This is a slide of practical implication. As it is being depicted and displayed over here, that a small mistake can prove to be highly hazardous when we don't design the ICU doors appropriately. Because in a situation of apprehension in fire outbreak, we need to take the wheeled ICU bed. We don't have that amount of time to shift the patient from bed to trolley. So we have to take the bed as it is. Since these patients are bedridden, mostly on ventilators, the infusion or the drugs, medicines are ongoing with much of medical cables. It is very, very challenging to shift the patient to the stretcher. Even a extra working force or man force is required. Hence, the width of the door should be big enough so that the entire bed should pass through. If If at all this width is not enough, this bed will stuck up at the exit point, and this will cause entrapment of the other patients inside the ICU. So this is of practical implication when we design the door of the ICU. Fire lifts should be, even the fire lifts should be spacious enough to accommodate the beds. Then thereafter there should be well marked fire manual call points inside the ICUs and at the premises, and everybody should be aware of it. Many a time this manual call points are there, but the personnel or the staff attending the patients are not aware of it. So it is important and mandate that all the staff should be knowing that where are these fire manual call points are. Then what is the significance of this manual call points? These manual call points are the devices which will alert the fire team, and they are also coded that way. The fire team will come to know where exactly this fire outbreak has taken place. So activation of fire manual point is important, and the first and foremost step when such fire outbreak is being observed. There should be well established code red team, which is a code name for fire outbreak. In a situation of, or in a scenario of ICU or hospital, uttering fire outbreak can cause apprehension and a kind of fear amongst the patient and relatives. In order to prevent that, we have coded this term as a code red. Just uttering this code red, the team and the fire rescue team will come to know that fire outbreak has taken place. Code orange is for disaster. So any form of disaster, as fire is one among them, these are the code words. Whenever we encounter the situation of fire outbreak, we have to utter these words. We have to constitute the team, code red team beforehand. We have to constitute this team, and we have to mandatorily get done the training annually in order to update the policies and the guidelines. So this is a reinforcement program which is to be conducted annually. There should be well-defined delegation of tasks with annual multidisciplinary training. The delegation of tasks, I mean roles and responsibilities of every staff member should be well-defined and should be known to the concerned person. The assembly point and checklist are to be prepared well in advance to prevent the last-minute chaos and confusion. Oxygen shutoff valves. These are important aspect as far as the ICU is concerned, because in an scenario of fire outbreak, the continuity of oxygen can be hazardous, as we all know that the oxygen will facilitate the fire further. So we have to interrupt it. But in the exercise of interrupting this, we have to interrupt the oxygen supply to the unaffected area as well. Hence, a design is being made that way that the walls are being channelized so that only that particular zone supply is interrupted, rather than interruption of the entire oxygen supply to all the patients. So this is predefined aspect which is to be incorporated so that the unaffected area will not be deprived of oxygen, and patient will be having the continuity of critical care management. Automatic fire suppressions, which has already been talked about, that in a situation of fire, the fire sprinklers will activated and they will sprinkle the fire in order to extinguish it. Then safe air exchanges. As sir has already pointed out that when we are using non-invasive ventilation, another 2 minutes please. If we are using non-invasive ventilation, then there is a fair chance, there is a potential chance that there will be a layer of concentrated oxygen in atmosphere, and this is causing this can trigger the further worsening of fire outbreak. Hence, the Anesthesiologist Society has recommended that there should be air exchanges more than 10, and that 10 per hour, and the formula has been given to maintain this safety aspect. There should be an evacuation box comprising of these medications and evacuation aids. There should be infusion syringe pumps in a stack system. And also this has a battery backup which will last for 1 hour or so. So we can just wheel on and shift out this entire stack of infusion pump. Oxygen cylinder to be kept at designated area. Type E cylinders, which are small cylinders, are useful. And one important aspect is refilling of the cylinders is to be done from authentic sources. Fire extinguisher should be well aware about. We shouldn't use the fire extinguisher which is not recommended. Hence, the specific and appropriate type of fire extinguisher is to be selected while choosing for the underlying cause of fire outbreak. Last slide, the take-home message is we need comprehensive modules with evacuation policies and plans well in place before the fire is being encountered. There should be defined role of human resources and logistics. The code red duty team should be allotted daily with periodic training and mock drills. There should be reinforcement session and simulation workshop. There should be periodic preventive servicing and replacement of equipments and all the medical gadgets. And there should be periodic fire audit, which is imperative. Thank you.
Thank you, ma'am. In the follow-up technical session in the intensive care unit, I would like to request Dr. Udit Narang from the medical intensive care unit, AIMS Nagpur.
Good evening, everyone. At the onset, I would like to thank our Executive Director, Sir, Dr. P.P. Joshi, Sir, for giving us the opportunity to come here and talk in front of you, and also the Director of National Fire Safety Service College for preparing this organizing this event. So I would not waste much time. Over the next 15 minutes or maybe 10 minutes, I would like to complete it. I would be going through this. We would like to cover these objectives to understand the importance of preparedness in critical ill patient evacuation, to define the roles and responsibilities of individual person, those who are working in the critical unit, that is a nurse, a doctor, a helping staff, or the supporting staff which is there in the institute, to establish a clear evacuation priorities, and to discuss the step-by-step process of preparing a critically ill patient. Now, the last point, I think Dr. Abhijit is there. He would be covering more in detail. I would be just going through a few points which are important from my point of view. So, as everybody till now has pointed out that ICUs are a potential place where the fire can happen, and there can be a difficulty which would be different from a routine fire which might have occurred in a ward or maybe some places, because of the challenges that there are patients who are immobile. There is dependence on life support systems. There are multiple equipments which are there, and that's, as Dr. Suchita has pointed out, that at that given moment there is already stress among the nursing staff and the doctors, and critical decision making may sometimes be hampered. So what we need is preparedness. So unless and until we are well prepared, we will not be able to handle these kind of natural calamities. And what it will help us in, it would help us in decreasing the mortality, minimizing the equipment damage. We are all concerned about saving life, but equipments are also important. And then
smooth coordination during the emergency. So preparation would consist of basically three things. We would require preparation in terms of equipments and resources and manpower, which is most important. And lastly, practice and mock drills would be equally important. So unless until we practice all those things, we conduct mock drills, there are training sessions which are held, all these guidelines will not be useful and will not be practically implemented when there is a fire. So well, let us first see equipments. Ma'am has already pointed out the best prevention, best policy is prevention. So while designing the ICU, it is important that we design the ICU in such a way that all the preventive policies are in place and the patient, the fire itself does not occur. But if unfortunate event occurs, then again we have to have some preparation which has to be there. So what is important from preparation point of view? That awareness about the fire call points. Your staff and people who are working in the ICU should be aware of the location, and the fire call points should be properly marked. They should be aware about the fire extinguisher, the positions of the fire extinguisher. Of course, the maintenance has to be looked into. Clearly marked oxygen shut-off valve. Now this is very important from ICU point of view, because as sir has already pointed out in the beginning, that increase in oxygen concentration can increase the chances of fire, further increase in fire. So we have to be very sure that it has to be, oxygen has to be disconnected from the patient, but not for every patient, because the patients are on critical life support. We are ultimately trying to save the life of those patients, but if we disconnect the oxygen before they are evacuated, they may die. So this is a very critical decision in the ICU, whether to disconnect oxygen or not to disconnect. We'll be going through it in more details in the subsequent slide. The other important resource is checklist or the local evacuation policy. Now there cannot be a standard policy which can be implemented all throughout the country, because every ICU would be different, the location would be different, the positioning would be different. Each hospital will ultimately have to devise their own policies. But those policies should be available in a digital form and also in a laminated form, especially at the place where the fire call point is there. Because whosoever goes, it is humanly not possible at that time of stress to remember every step which is involved in these evacuation processes. So it is important that we have a checklist which we can utilize to execute the process in a seamless manner. We should have a properly defined evacuation route which should be displayed at various different places, and it should be illuminated with emergency lights. The illumination, the laminated evacuation card defining the roles and responsibility of individual person who is working in the ICU is important. So the nurses should be aware of what roles and responsibility they have to do. So this is from NHS. This is their evacuation card, fire evacuation card. This is an example of this. I think Dr. Abhijit would be going more in detail of this card, what all it should have and what it consists of. The next important resource is we have to have an evacuation kit. Now this evacuation box should be available ideally with every patient. But then when it is not possible in our setting to have it at every bed, it should be accessible at places which is maybe shared between 2 beds or 2 or 3 beds where it can be easily found. And this kit should have important drugs which might be required for maintaining the patient if the patient is being shifted out, because even once the patient is shifted out, we have been able to shift him out into the assembly area. We should be able to maintain the patient. So some emergency medications like inotropes, which are required for increasing the blood pressure, should be available. Sedatives, patient may fight with the ventilator, so we may have to sedate the patient, all should be available. Syringes, lines, vasopressors, the torch, and most importantly charts, because when the patient is being shifted, we have to take care of the patient. So continuity of care is very important, and that continuity of care has to be documented as well. कुछ दिया है तो वो पता होना चाहिए हमें कि वो कहाँ दिया है, क्यों दिया है और कब दिया गया है. So इसलिए if possible, but that is not mandatory. अपनी लाइफ को थ्रेट में करके हम पेपर इकट्ठा करते रहें, that is not required. But then if possible, we should try to have those things available with us. So we need to have evacuation aids in the ICU. Now these aids I think will be covered in more detail again by Dr. Abhijit, but I would like to emphasize that we need to have beds are the best mode, and Dr. Sucheta has pointed out that we have to take care that it has to go through the door, and even the pediatric patient जो बहुत obese होते हैं उनके special beds होते हैं. So it is not just the normal general Fowler bed which is important, but it is the pediatric bed which we should be able to cross through the doors. So the size of the door should be that. Evacuation chairs can be used only for conscious patients. It cannot be used for any patient, because evacuation chair, as you can see, the patient has to hold the chair. So they are good modes of faster mode of transport or evacuation. If stairs are to be used, if unfortunate event there is no ramp available or the lifts are not working, but then it can be only for use for the conscious patient. Otherwise we will have to use sheets which can be given. Smoke hoods are important aspect. Now smoke hoods are not mandatory for medical ICUs, but it has been seen in various studies that presence of smoke hood can increase the time duration for which the evacuation can be carried out. So it is not a bad idea to have smoke hoods, for at least 1 or 2 smoke hoods which staff or the doctor who is there on duty can wear and can help in evacuation and can prevent self-harm and help in further maybe for a longer duration of time. Oxygen cylinders have already been told that we need to have. There is no proper standard guideline what number of oxygen cylinders should be there, what quantity of oxygen cylinders should be there, but it should be enough for shifting your patients outside, because majority of your patients would be on this thing. Apart from this, we would require transport ventilators, ambu bags, Bain circuit, which will help in manually ventilating the patient if they are being transported outside. Roles and responsibilities. Now there are again no proper set as such guidelines कि ये role इसी बंदे ने करना है. It is that there can be an overlapping of the responsibility, but we can have some standard guidelines depending upon the work environment in which you are working and the availability at that given moment. So first and foremost, nurses are always available in ICU. So they would be the first person probably to detect smoke. So their important role and responsibility would be to recognize and react. They would be the one who can recognize using various things. They would be the one who would be activating the alarm system. And they should be well aware where the alarm system and how it is to be activated. This is the first role and responsibility. Second is they have to prioritize the patient safety. So if the fire is in a particular area where the patient is already there, the first and foremost thing is to remove that patient from that particular area. But how to otherwise prioritize evacuation, we'll be seeing in subsequent slides. Prepare for evacuation. That means they gather necessary equipment like evacuation box, which we have discussed, transport ventilators or equipments which might be required for evacuation. Assist in evacuation is their role and responsibility, and provide continuity of care. This is most important. That means they have to, during the transportation, ensure that the IV line access is there, the oxygenation is being continued, because they are the one who are treating the patient at that given moment and would be aware what all is going on. To collect the charts and also the important medication which might be required, anticipation of those things would also be a thing which would come into the nurse's duty. Doctors and paramedics who are available, they can form a rapid response team. Triaging is the priority of the primary responsibility of the doctor. Now, as I've already told you, oxygen shut-off valve are important, but then whether to shut that valve off or not should be the decision which should be taken by a doctor, because if we shut down the valve too early, it can also cause damage. If we don't shut down the valve, it will be a delayed response and it can cause further increase in the fire. So again, that is very important. And while preparing, or maybe when the ICUs are being made, at that time maybe we can have different areas, maybe different number of beds which can have different oxygen supply, so that suppose the fire is in one corner, we can shut down the oxygen supply of only those 4 or 5 beds, whereas the other patients can continue to be on oxygen and on the ventilatory support till the time their number or they are being evacuated. So safe transport facilities. Do I have 2 minutes? So safe transport is important. Again, communication with other hospital where they are being evacuated is important. Clear evacuation, support staff needs to clearly evacuate the route. the important about the evacuation route is that primarily when the patient is being taken, we should ensure that the patient who are on dialysis, who are on some machine, ECMO, they are kept at the corner, because if they are in the front where the evacuation is to be taken place, then they would block the way and evacuation would be difficult. So these are all preparations which have to be made even before the fire sets in. Logistical support, communication, crowd management is the responsibility of support staff. I'll not be going into these details. This would be covered by Dr. Abhijit in detail, but important point here is triaging of the patient. So whom to transport, and when the evacuation decision is taken place, then who should be transported. So should we transport a unwell patient? No. A patient who is very critically ill on multiple life supports, multiple infusion pumps is less likely to survive. But it is going to take more time for you to prepare and evacuate that patient, and you are going to lose time. So the guideline mandates that patient, first of all, even if he is unwell but is very close to the fire, he needs to be moved to a safer area first. That is most important. But after that, if the evacuation has to take place, it is the most healthy patient which will be evacuated first. That is the least unwell, followed by the most unwell patient. And those patients who are in side room, who are in some other room, they would be the last to get evacuated irrespective of their status. Special consideration, I have already told you that we have to take into account the disability. This is from the Ministry of Health guidelines about what patient to be evacuated. Assessing the patient about disability, how do we decide whether they are unwell? So there are various, doctors can take into consideration various parameters like the vital signs, blood pressure, pulse, whether the patient is on ventilator or not, a Glasgow Coma scale is there. All these things would help them in identifying the priority. And ultimately, once they are shifted out, but the priority changes completely opposite, once the patient are at the assembly point, the assessment or the reassessment of the patient would be first for the ventilated patient and followed by the other patients who are not dependent or maybe who are comparatively independent, not on oxygen support. The good medical practice emphasizes one thing. So it states that a doctor must take prompt action if they think that the patient's safety is or may be compromised, and offer help in an emergency arising in a clinical setting, taking into account their own safety and competence and the availability of other options for the care. So unless and until you feel that you are safe, you will not get harmed, because if you get harmed, maybe there would be more mortality. You should not execute the safety procedures or safe evacuation. So most important is that first ensure your own safety. Once you are so sure that you are safe and you can do the things, then execute the evacuation. And as I have already pointed out, too early evacuation would harm the patient because they would be transferred out and the treatment would be compromised. A too late evacuation would again cause harm to the patient. So it is very important to cover all these things. So I'll not be going into these steps. It is detection of alarm, initial response, oxygen shut off. I've told you it has to be shut off only when the patient, you are sure that the patient is in very close to the fire, or maybe oxygen is the source for the fire. But other than that, the part of the ICU can still continue to receive oxygen, and then the oxygen can be in a stepwise manner be cut down. Patient preparation, evacuation, and continuity of the care. So I'm not going into the details of what all to be done. This will be covered by Dr. Abhijit. So we need to stabilize the patient, ensure that all medical equipment, infusion pumps, ventilators are available. We have ambu bag which is there for ventilating the patient. Documents, if possible, need to collect, but before evacuation, we need to give a pre-briefing of what we plan to do. It is not that I individually should do everything without having discussed with my team. So take a time, don't panic, think what is to be done, what is safe for both you as well as for patient. Give a pre-briefing to stand as a leader, and then execute the evacuation. So these are again hazards: oxygen, smoke, electrical equipment, lighting. Water, I would like to just emphasize one thing. So there has been a debate regarding the availability or presence of sprinklers in ICU. So it had been thought that sprinklers would, once they are on, mist sprinklers, it would spoil the equipments, necessary equipments which are there, and may jeopardize the safety of the patient. And there should not be sprinklers which should not be installed in the ICUs. And secondly, again, exposure to cold or wet because the patient cannot take care of himself can possibly again worsen the patient's condition. So hypothermia vagere can set in. But it has been now proved that sprinklers would cause rather less harm than more harm. So they should be installed, but we should have provisions for plastic sheets to cover the patients in case of this is there. Special consideration for HIV positive or immunocompromised patient. Again, during transportation, we should be sure that the communication of infection is not there. So we have to maintain all those universal precautions during transportation. Lastly, these are the challenges for fire evacuation. So we have to, logistics as an issue, fatigue could be an issue. Once the staff has shifted out, again it is important to take care of those staff as well, and limited availability of resources could be there. So these are the guidelines specific to the Indian scenario. There are guidelines from National Disaster Management thing, so in which they have mandated the audits and training of the staff and evacuation protocols for each hospital. There has to be an evacuation route planning which has to be there. So I'll not be going into those details. In the end, just I would like to emphasize that fire evacuation requires preparedness, teamwork and clear communication. We need to adhere to guidelines, and regular drills are important, because without drills, without preparedness, we cannot execute the thing no matter how knowledgeable we are. Patient triage and equipment security must be a priority, and the evacuation has to be tailored as per individual hospital's requirement, and it cannot be generalized to each and every hospital. Thank you so much.
Thank you, sir. In the same intensive care unit, I would like to call Dr. Abhijit Chaudhary.
Good afternoon. So I hope that few slides there will be an overlap, and I hope that few of the people are from the hospital background. So now my topic, I am a clinician, I am a pediatric intensivist, and my perspective of this talk would be from the clinician perspective. So I will be talking about evacuation of ICU patients in case of fire. Fire happens. Now we all know with the two topics, and for the last 2 hours we are hearing that fire happens in hospitals, fire may happens in ICUs and OTs, where evacuation of patients is a complex thing. So while I was reading about this topic, this is a wonderful incident which was reported in one of the journal of a fire in a ICU, adult ICU, which Dr. Sushita madam had also discussed, and the inciting agent of the fire was oxygen cylinders. And when they found in the last, in 2008-2009, there were 5 incidents of fire in UK, and majority of the fire incidents were because of oxygen cylinder. Just see their response. 9:20, the oxygen cylinder caught fire. At 7:20 in the evening, the fire took place, and by 7:40 the patients were evacuated. So this is a very good article. What steps they had taken. ICUs, OTs are at risk. This is the fire triangle, what they call, because ICUs, they have fuel for fire, they have oxygen for fire, and they have heat for fire. And my topic would be on the evacuation. Now first and foremost things, after the Dr. Udit's talk also, you know what is the preparation. Now suppose there is a fire alarm, there is a code red. The first and foremost thing from the clinicians, nurses, paramedics perspective is there a need of evacuation? That is the first thing. ऐसा नहीं fire alarm सुना और चलो भागे. So in case of fire, evacuation is performed once preventative and suppression measures have failed to contain the fire and the lives are under immediate threat. So means the people who are working in ICU should know how to contain the fire. And then once fire alarm is triggered, immediate action should be true alarm hai ki fire false alarm hai. And then when you establish that it is essential, then only evacuation process should be carried out. Now evacuation of ICU and OT is a complex thing. हमने कई बार देखा हॉस्पिटल्स में आग लग गई, ट्यूशन क्लासेस में आग लग गई, there the picture is different. Here in patients are on equipments, patients are on oxygen in ICUs and OTs. And most important thing from a clinicians and paramedical perspective is I should know my fire exits. Guidelines recommend there should be a 3 fire exits, and these fire exits should lead to fire safe areas. This is also very important thing. I should have a knowledge of fire extinguisher. Now the guidelines say carbon dioxide based fire extinguisher is more preferred because foam based fire extinguisher can have a corrosive effect on the medical equipments. And I should have a knowledge of my oxygen gas shutoff valves. Mind you, before when I was doing my intensive care training, not a single lecture was there on fire. After I joined AIMS, after our engineering department started taking classes, then only I was exposed to this fire hazard. Oxygen shutoff gas valves, I should have a knowledge. Ideally, the ICU should be designed in such a way that there should be cubicles where they have, each cubicle have a separate oxygen shutoff valve. Now, once there is a fire, you decided for evacuation, I have the knowledge of where to exit, oxygen gas shutoff valve, I have the knowledge of fire extinguisher. The first thing is assign roles and responsibilities. नहीं तो सबसे पहले क्या होता है, मैं कहाँ भागूँ. You assign roles, you assign responsibilities, and the team would be, immediate team would be of doctors, nurses, paramedics, and the fire officers which are present in your hospital. And one person has to be a team leader. See, this is a very tricky situation. This is like a fire in ICU. It's a very tricky situation. Now, this I am emphasizing again. Here in triage, suppose कोई railway accident हुआ, sickest patient को सबसे पहले care दिया जाता है. But in fire, it's a reverse triage. So evacuate first, less sicker patients, easily transport patients, and nearest to the fire. Whereas evacuation last, more sicker patients and patients in the side rooms. Now majority of my talk is basically on these 3 photographs. What we have to do as a clinicians, as a paramedics in this situation. When see a child who is on ventilator, this is the OT picture and this is the medical ICU. So what exactly needs to be done? If you have to, first and foremost thing, assign roles and responsibilities, then the team members have to bring the oxygen cylinder. Hence your oxygen cylinder has to be in the central area of the ICU where it can be easily pulled off. Provide oxygen to the child. If there is a facility, you can shut off the oxygen supply of this cubicle if such is the need, and then take the child, remove the child from ventilator, patient child from the ventilator, take him from on a handbag and start the process of evacuation. With this, see, there are so many drugs which are going on, the patient may be on the ventilator, so many steps need to be done. So what are the immediate steps? The first thing, all equipments and drugs are rationalized to minimum required for ongoing life support. Very important, it has to be done quickly. जितना ज़रूरत है उतना rationalize करो, उसी को लेके बाहर जाना है. Equipments, आपने देखा होगा यहाँ पे बहुत सारे equipments हैं, इनसे disconnect करो. Many equipments will work on battery, but even batteries fail. They have a very short period. And please take the patient's charts, क्योंकि हमें उनको evacuate करके आगे और manage करना है. So try to take the patient charts. Now this is important, mechanical ventilators. We can't pull mechanical ventilators with the patients. So if it will be desirable कि patients are shifted to gas driven ventilator, or just they are shifted to a handbag which we call AMBU, and they are supplied with they are transferred with the oxygen cylinder. Now Dr. Udit had already spoken of the evacuation box. Now each, ideally 2 to 3 patients of ICU should have a evacuation box. And adult patient may have different drugs, pediatric patients may have a different drugs, but the concept is same. Have anesthetic agents, neuromuscular blocking agents, IV fluids, vasopressors, and ICU charts. And with this evacuation box, you shift the patient. Now, what are my agents for shifting? Either I can use fire sheets, which should be available in your ICU. Patients can be shifted on chairs. Children or patients who are mobile, they can be shifted on fire chairs. Those who are not mobile, they can be shifted in the fire sheets, on the trolleys. So blankets, wheelchairs, canvas stretchers, and backboards, they should be available in the ICU, and with their help we can shift evacuation. Now horizontal and vertical evacuation strategy. all the fire officers, they know better than me, but horizontal evacuation is preferred. Matlab, preferably ICU should be in the ground floor or the first floor, and there should be an area on the same floor where I can shift my patient. That is horizontal evacuation strategy. And vertical means आप नीचे या ऊपर जा रहे हो, नीचे ground floor पे या ऊपर जा रहे हो, and you have to use the lifts then. And important है कि lifts को dual supply होना चाहिए. Now, so what during a fire? Safety first. Safety of first of the persons who are evacuating patients, then patients. Triage of patients is very important. Sicker patients बाद में, less sicker patients, easily transferred patients पहले from ICUs. And important thing is they should be transferred to a place. Means आपके hospital में पहले ही identify करके होना चाहिए कि यहाँ आग लगी तो मैं इस patients को कहाँ shift करूँगा. Okay. So in a nutshell, in fire, close all the fire doors in your area. Ensure egress corridors are clear. Locate and secure patients' medical records, medical supplies, and ready evacuation transport equipment such as wheelchairs, blankets, and gurneys should be available. And you should be shifting the patients to assembly point. So, such kind of, these are basically taken from the UK health system, and such kind of charts should be available in all the ICUs, जहाँ पे specific instructions रहेंगे कि अगर fire हुआ, so this is a evacuation chart. आप क्या करोगे? Activate करोगे, coordinate करोगे, high flow nasal cannula, जो भी oxygen rich equipments है, उनसे patients को निकाल सकते हैं और normal oxygen पे डाल सकते हैं, वो assess करोगे. Attempt to tackle fire using fire extinguisher, everybody. Operate both oxygen shut off valves in main corridor. अगर cubicles है तो ही कर सकते, पूरे ICU का एक ही oxygen shut off valve है तो नहीं कर पाएंगे. Prepare patients for immediate evacuations, assign roles, responsibilities, take a evacuation box and evacuate patients to a safer place, preferably to another ICU area. Now this is very important. This was a fire incident which had happened in PGI Chandigarh, where I had taken my postgraduate training. So post-evacuation is very important. Immediately after shifting patients, बात वहाँ खत्म नहीं होती है. You have to continue the patients there. है ना? ये tuitions नहीं है, या फिर कोई घर में आग लगी नहीं है कि आपने patients को shift कर दिया. Probably if they are not injured, उनको सिर्फ care की ज़रूरत नहीं. These are all patients who are on treatment, and ongoing treatment is very essential. Monitor patients closely. मतलब एक वहाँ की टीम, आपने कोड रेड एक्टिवेट कर दिया, अब आपको हैंडओवर देना पड़ेगा आगे के डॉक्टर्स को, नर्सेज को, और मॉनिटरिंग इंस्ट्रक्शंस देने पड़ेंगे. And this is the most important thing, provide emotional support to patients, to doctors and staff. Ideally those who have been in this incident, उनको ड्यूटी से छुट्टी करना पड़ता है. Next team has to take care, and immediately these doctors and nursing staffs have to be reported to psychiatrist for their psychological rehabilitation. So the take home messages is immediate response has to be there to fire in ICU, remove the staff and patients from immediate danger, alert the switchboard and fire department, contain the fire by closing doors and windows, extinguish the fire by fire extinguisher, and after that evacuate the patients. Reverse triage is applied at this stage. सबसे important, reverse triage, and evacuate visitors, most stable patients first and most unstable patients last. Thank you.
Thank you, sir. In the same session of intensive care unit, I would like to request Dr. Nishan Banayat, intensive care unit, AIMS Nagpur.
Good afternoon all. So I think the whole talk or today's session is very important from the point of view of all hospital patients, of course, but the most vulnerable patient in any hospital is the newborn, because they are completely, absolutely dependent on the caretakers. They cannot do anything for themselves, and we hear this news unfortunately every year. There are one or two incidences where newborn units catch fire. fire, and some babies lose their life, which is very unfortunate events. Sadly, unfortunately, even after all these years of such fires, there are no concrete guidelines from any agency how to deal with these NICU fires. That's a very important question. Every year something happens, we all say very sad and sorry, and there is another event the next year. So when we started this NICU at AIMS, we wanted to address this issue right from the start, and we looked at what is available in the guidelines or guidance is available. You'll be surprised there is hardly any guideline specific to NICUs, specific to NICU fires. So I'm not going to discuss what other people have been doing, what we are doing in our NICU. That's what we are like to discuss. So I am neonatal intensivist, so I take care of small premature babies who are born very small, right from 500 grams, and these are, as I said, as the most vulnerable patients. What makes them vulnerable? You can see in this picture a small circle I've made. That's a tiny foot of a preterm baby, and he's surrounded by all sorts of equipments. These babies are very peculiar in their complex requirements. They almost always need some kind of respiratory support, ventilators, and they are absolutely dependent on the caregivers. And they are very sensitive to change in temperature, either high or low, and handling. So babies can just die because of that. Why these NICUs are catching so much of fire incidents? Unfortunately, there are no post reports that we get as an intensivist that why certain NICU caught fire. But it's a very heavily dependent on electrical gadgets, and you can see these babies being at this point in time more than 10 equipments. They're all electrically powered. So these are one of the few reasons why these babies are so vulnerable, why these NICUs are so vulnerable to catch fires. Any NICU should have an emergency operation plan. This is the plan we have made for our NICU, and I'll be mostly focusing on how to respond to a fire, mainly on the evacuation side. So any hospital should have clear evacuation. These are all images from our AIMS hospital. We should have a well-identified route for horizontal and vertical evacuation. And all staff who are working on the ground, they should have the knowledge of this horizontal and vertical evacuations. So what is horizontal and vertical evacuation? So when you're having a fire on a particular floor, but you're safe that babies can be moved to another side where there is no fire on the same floor, then it's a horizontal evacuation. While vertical evacuation is essentially meaning you are changing the floor, either you are moving out of the building completely or going from, say, second floor to third floor to second floor, which is the case in our NICU. So this is the plan for our horizontal evacuation plan for our NICU. So just by the side of NICU, we have birthing center where babies are born, and we regularly practice drills of this horizontal evacuation. This is a picture from there is the birthing center, and then we move trolleys which take care of babies to the birthing center. These are the small drills when we are carrying out horizontal evacuation of babies, of ventilated patients. So you can see 4 people are moving one baby, because that's how we have to be personal intensive for one baby, because they need somebody to carry the trolley, somebody to carry the ventilator, and somebody to carry the oxygen. Then these are our vertical evacuation routes which we regularly practice. We haven't done a drill yet, but we'll plan soon. Then evacuation, we have mainly divided into 3 categories. One is role assignment or job cards, then triage and step-by-step process of moving a critical patient versus a stable patient. So these are the emergency documentation kit which we keep. They essentially have job cards, they have patient tracking forms, and then we have a stepwise guidance for evacuation of critical and stable patients. we are prepared for whoever is on the duty and who is the leader on that particular day, on that particular time. So it has very clear specific instructions, written instructions, because you can imagine whoever is very experienced person but still can always essentially panic in a mode of any event like fire. So people can get confused and do mistakes. So we have prepared job cards we are very specific and clear objectives. So this, for an example, I have described a job card here where the leader has to do certain things. He has to alert the safety services and administration. Then, particularly for our NICUs, the the labor room, that they have to stop all the non-emergent deliveries so we don't have more babies coming in, and establish communication code red, assign each room a different leader their own jobs, so distribute their own job cards, and then subsequently take further steps. So this is a job card for a particular room, what a person leading that room should do. Then a job card for a duty doctor who is on there, and bedside nursing officer, what that nursing officer is supposed to do in a stepwise manner. And for the attendants in the NICU, we have different job cards which is in Hindi for their understanding. So the leader has to distribute all these job cards, and the job cards, then it becomes sort of very clear for each individual what their role is and what they have to follow. Another important thing from patient evacuation is, essentially you can get confused with babies. You don't know one baby with another. You don't know. You will misunderstand this is another baby and this may be actually the other baby. So we have designed certain forms where patient is tracked throughout the evacuation and essentially having their identification marks also. Then next step is triage, how to decide which babies go first, as most of the speakers have already told. It's a decision of the on-duty physician, but the general rule is the babies who are nearest to the fire has to be evacuated first. Then babies who are stable and can be easily carried while wrapped. And then the last is critically ill infants who require respiratory or ventilatory support. So this is, you can see on the right, carrying two babies in one bassinet because the babies are stable and they don't need much of respiratory support. In Western countries, they have designed certain vests. I will like your inputs and collaboration. We will design certain similar for fire-resistant material. We can just put the babies in the vest pockets and move them. Then this is a baby who requires some degree of oxygen, not ventilator, so 2 persons will be required to move the baby. Then for a baby on a ventilator, you can see there are at least 3 to 4 people required to transport this baby from one place to another. Then while doing these drills, something we encountered was how do we follow steps of what needs to be done first and what needs to be second and third and fourth. So people were doing multiple things at the same time and would cause errors. So we designed a sort of flow chart where each step is documented and also the person who should be taking that step. So we sort of color coded it so that everything yellow will be done by a doctor, everything purple will be done by a nurse, and everything green will be done by an attendant. So these sort of charts are designed for critical patients and stable patients as well. This is a checklist which we will use in case of evacuation, that we have followed the steps in a right way. Then certain fire evacuation devices which we don't have but we like to have, used in UK. These are sort of fire old babies can be put in this trolleys and can be moved. This is something which can be designed, and as I showed you the evacuation vest before. Then Dr. Udit and Dr. Abhijit has already talked about bedside evacuation packs. So we have also these packs designed with us, and we are using them during our. So these are the contents of a typical evacuation package we are using in our NICU, and these are the contents of it. So we keep on regularly checking ensuring that everything is in place and in order in case of an emergency. Then something we have also realized that once a baby is being moved from one place to another, baby's treatment needs to be ongoing. We cannot say that the baby is moved and it's all fine. So for the ongoing treatment, we designed these trolleys where again the contents are listed here, and these are the trolleys which are required for their ongoing management at the site of evacuation. As Dr. Vijit also emphasized that at the assembly area or where the evacuation area is, you need to again reassess these patients, ensure that they are returned to their original treatment, original devices, and then document and objective assessment of the patient's condition should be done. We have to maintain ventilation, we have to maintain temperature, we use different devices for that, and their infusions. So babies are absolutely dependent, so you cannot say a baby can be left without an IV fluid or a feed for the next 1 hour, so we have to carry out these things to the evacuations. If unfortunately if the fire is not controlled and you have to move out of the your own hospital, then critical babies should be transported to other level 3 NICUs, while some stable patients can be shifted to level 2 NICUs. Last but not least is demobilization and recovery. Once everything is settled, you go back to normal operations. And there is a recovery, there is a long-term activities such as restabilizing personnel, repairing equipment, and restoring resources. That's how we would like to, that's what we are doing at AIMS, and we'd like your inputs on this if this can be modified in some ways. Thank you.
Thank you, Sam. With this, we end the technical session 1. In this, the intensive care units, which cover the 4 variety of medical, surgical, and pediatric and neonatal, all these intensive care units has been covered. Now, we'd like to give a comments from the chair for all these 4 sections. So I would like to request our panel members to address the comments on this technical session number 1.
Thank you for all the good presentation. It was really a pleasure to see the doctor are giving such a good presentation. It seems they are the fire expert and we are learning from them. So a big clap for all the doctors who have given this presentation. Really very, very good, very, very informative for us also. This is a really good presentation made by doctors. My recipe for, for hospital fire, because I day, night and I am dealing with the, the hospital fire, regular fire. Hospital fire is one of the most difficult fire as far as the firefighting are concerned, rescue operations are concerned. What I will suggest to all the doctors, all the sisters, nurse, paramedical staff, they must be trained. It must be in the syllabus for the nurses, for the supporting staff, about what to do in case of fire. Because see, you are the first responder in the hospital. You are in the hospital, you are inside the ICU. We will be reaching almost after 10 minutes, 15 minutes, depending on the traffic on the road, firefighter. So the initial 5 minutes is very, very crucial. And all doctors, all nurses, all staff must know what to do in case of fire. That is a recipe. Fire NOC, fire certification, fire equipment is one part. Second part is that how to save the life. And the life can be saved only by practice, training, only training. I will just quote it as an example of the Delhi fire where so many children died in the case of fire in Vivek Vihar, where when we reached there, nobody was there, no doctor was present, no nurse was present, and what the neighbors were doing the rescue operation. We reached and we have to struggle with the way how many children are there. Nobody was there to guide it. So my request to all the hospital superintendents, all the doctors, that they must know what to do in case of fire my sister nurse must know what to do in case of fire, how to evacuate, because the first responsibility to take out the patient is with you. We will be there, we will be supporting you, but you have to inform us. Like in case of Evacuation fire, where so many children died, we were not knowing how many children were there in the nursery and how many we have recovered almost 19, and then there somebody told me one more is there. So, as I am telling as a practical, because the chief of Delhi, that unless we practice it, nothing can be done. There are all, we should do this, we should do this is available, evacuation procedure should be there. But we have to regular do drills. Regular means everybody should know what to do and they should not run away. Like I will quote an example, like in aircraft, the air hostess knows in case of emergency how to evacuate, what to do. She will guide us how to go out, and then she will do other thing. This type of thing should also be in the hospital. Then only we can achieve a zero tolerance, no death, complete fire safety. Thank you so much.
Thank you, sir. All the faculty members from the AIMS delivered a very wonderful talk, and it is quite informative. First one, Dr. Bhaute madam emphasized on the fire safety guidelines, and she emphasized on the ICU, why it is vulnerable, why the short circuits happens, and how the fire takes place. Also, she emphasized on the importance of the carbon monoxide and SCN. Also she emphasized how audible alarm and visual alarm very important. She especially emphasized on that. And also all private hospitals need a NOC from the fire department. And in Nagpur there are more than 650 private hospitals are there, and every hospitals need for NOC, and we ask compulsory to provide the NOC from fire department. Second, Dr. Narang emphasized on the preparing the patient for clinical care, focusing on that, and he also emphasized on the practice for mock drill. Just sir told about that, why the mock drill is important. How the oxygen shut-off valves are important, he also emphasized on that, and what are the various local evacuation policies that is important for every hospitals, he emphasizes on also. And how is the emergency evacuation box is available, should be available at ICU as well as the OT, and which are the important evacuation aids, he emphasizes all on that. Why the patient, how is the patient's triage, we will give importance to them, and what are the roles and responsibilities. And lastly, he emphasized on the teamwork, because not only the doctor but all the team members from AYA to class 4 workers to class 3 workers, all are important. And if until and unless we do not involve all the members, we cannot evacuate the hospitals properly. After that, Dr. Abhijit Chaudhary emphasized on safety evacuation of the ICU patients. He elaborate all the important aspects. Also, one or two things we emphasize on the re-establish of the care of the patient, because we are evacuating, but after that, that is very important point. And also there is need of the emotional support to the patient, to the relative, and to the team also. That is also important. Also he emphasizes on the mock drill also. And lastly, Dr. Banayat, sir, also emphasize on the NICU, how we will shift the newborn while there is fire breakout in the hospitals, and he emphasizes on the evacuation plan, how is the route it will go, and in AIMS how they are using the horizontal evacuation as well as the vertical evacuation, and in AIMS hospitals they are giving the job card for every individual HR, and how they will use that is also important. And also he emphasizes on the step-by-step evacuation plan there. So overall, all the 4 lectures are the wonderful lectures, very informative and eye-opener, and I hope that it is very informative to all the private hospitals or those who are attending this seminar or the workshop. Thank you very much.
Thank you, sir. It was a really good technical inputs provided by all the sessions during all the sessions. Would like to have the decided frequency for all the actions suggested there. Guidelines also should be framed as an SOP, and sort of tabletop exercises that frequency of that particular small or little exercise, they can voluntarily suggest the frequency, and that should be regularly carried out, that tabletop exercises, because this kind of the emergency is a little different for the even hospital also. Means evacuation themselves. You have got a lot of potential to admit more and more patients. It has been such a things are happening. But when you will be asked to evacuate, then definitely it will be a different thing. And tabletop exercises should also be conducted within the hospital and with the help of the nearby hospital also. Thank you.
Thank you, sir. With this, we close the session 1, and thanks for the insightful expertization from the All India Institute of Medical Science and the 4 intensive care units that they have been brought out, what actually the reality with the pictures and subsequent demonstrations also. With this, we are closing the session. Now, moving ahead, we'd like to continue Dr. Deepak Selokar sir to continue with the session, and okay. Now we close the first session. Sir, thanks for your comments and addressing to the first session. Thank you, sir. Now moving ahead, for the next session, we'd like to invite the Dr. A.R. Sondeke sir, Professor, National Fire Service College, Nagpur, Sri Prashant Lunkar sir, Fire Advisor, Ministry of Home Affairs, Government of India, Dr. Aradhana ma'am, Airport Authority of India, for the second session, the session theme is preparation of the patients for the safe evacuation. In this second session, Dr. Sarita Jogelkar, MBBS, DA, DNB, consultant anesthesiologist from the National Cancer Institute, Nagpur. So, we'd like to welcome you, ma'am.
I would like to thank the National Fire Safety College for giving us the chance to express ourselves for the fire safety measures. Particularly, I am dealing with the operation. As we all know that when it is fire safety is a paramount concern for the healthcare facilities, ensuring the safety of the patients and the staff and the visitors or alike. Now, when we say that we have to concentrate on the safety of the patients, we have to know what are the sources of the fire that can come as a sources in the hospital for the fire. So we have the, as it has been already said, all the hospital kitchen, overuse sockets, cables, medical and surgical equipments, smoking, confined fires, heating system, gas cylinders, hot surfaces like light bulbs and radiations. Now, the need to evacuate an ICU or operating theatre complex during a fire or other emergency is a very, very rare, because most of the time we know that the fire that is catched inside the OT or the ICU, the evacuation is an extreme task, and we all required the regular drills and practices to handle this type of the situation. Now, what is the most important? Everyone knows about the race and pass, but most important thing is avoid the panic situation, be calm, be patient, whatever the gestures, whatever the movement of the staff in the OT, or it is OT, most of the patients are anesthetized, but if you are in the ICU area or other areas where the fire is catched, there's all possibility that your gestures are going to hamper the calmness of the patient. So try to be calm, try to be patient, and understand what evacuating everyone's safety is only your responsibility. You are the only point of source to evacuate the patient very deliberately at this junction. Then start the patient assessment very rapidly. Now, if we are enough trained to have the fire mock drills done, we have already assessed the ICU patient, we have already assessed the OT patients, that which patient needs to be safely transported early. Because OT is a critical area where most of the time the ventilated patients are here, and we have to tell the call according to the point of the surgery, at what level of the surgery the surgeon is, and what surgery is to be completed fast, or whether we need to wait for some time, or we have to hold on and ship the patient. So at that time it is assessment by the surgeon. Mostly surgeon is involved in doing the completion of the surgery work. So it is the intensive anesthetist who is monitoring inside the OT, has to take a call what type is to be wind up fast and what is to be shifted very urgently. Now it is the diagram which shows immediate, rapid, gradual and prepare only. These are the 4 modes where we have to execute ourselves with the mocks and drills. But where the mocks and drills are useful is in a rapid and gradual. Prepare only gives us enough time where even if we are not protocolized, we can have ample time. But if it is a gradual, we are getting several days. But if we are rapid, we are getting only 1 to 2 hours. So immediate, there may be a hodgepodge when we don't get a time enough to protocolize the things and take the patient out. But rapid is the area where 1 to 2 hours time, where the mock drills will help us to control the evacuation in a very systematic manner. And I will insist that rapid and gradual both is to be focused by the mock drills so that the evacuation can be rapid. It has been already covered. I will not insist upon that. We all know that it is a horizontal, vertical and shelter in place. This type of the movements are there. Most of the time, as we are concentrating in this lecture on the operation theatre, I will say that the horizontal evacuation is very, very important. Some safe area at the other part of the building, which is on the same floor, is to be catched. It is to be prepared so that we can continue the remaining surgery on the other part, and we can safely evacuate the patient from the fire area. So it is a horizontal evacuation which is most important. Vertical evacuation may be needed for the dependency unit patients, where we can safely turn them to or shift them to the area where we can evacuate and maintain both fast. Shelter in place, staff may be instructed to shelter in place, that is remain in the units and await for the further instruction. This scenario is not going to happen in OT. This is for the general wards. As the triage of the patient has been very nicely covered, which is just a repetition. Evacuation the patient nearest at the fire first. Evacuate the least unwell patient, means most well patient or a normal patient or near normal patient. Then evacuate the most unwell patient, and evacuate the patients with the syndromes is to be done last. Bariatric beds is a big challenge, as well as ECMO patients are a big challenge when they are in ICU. So in the OTs, if the bariatric bed is there, even the normal patient is taken for some surgery, or the bariatric patient for normal surgery is taken up. Carrying this patient is very difficult, but when we are conducting the OTs, we have the bariatric OT tables. They can be movable at the times if they are required with the ventilation continued. Now, as we have already said, this is a triad established, immediate danger, ambulatory patients, patients in general. Here you can see that patients in OR are coming in the last of the gadgetry. But if we have the OR tragedy or the fire catch, it is important to note that the surgical procedures that has been initiated should be completed to a point of safety before the patient is moved, because now operating theater patients may be 10. If there are 30 operation theaters going on, we are getting ample time. If the fire is at the one end, the rest of the OTs can be completed. So there could not be hodgepodge at this time, and we can take safely the patient out by continuing the surgery at the other end or giving a time gap arrangement to the shift to patient to the other area where we can complete the surgery with the resources available or with resources which has been planned early for such type of measures or calamities. This has been widely explained earlier that evacuation cards are very important because we are getting the material on Googles and everything. The materials at fire and guidelines are elaborating the same. So slides may be the repetition. We will concentrate here on the principles where now suppose it is the OT area. OT area, if we are shifting the patient, if we are completing the patient, the anesthetist will be accompanying the patient. But transferring the OT patient may require some human help more than the gadgetry help. And human help means you are risking that number of staff more for shifting the patient. So shifting gadgetry should be well compact. The anesthetist is well trained to take it on the ventilator or the transport ventilator, or even with the ventilating bags or ventilators, ambu bags to the area which we are designed in case of such patients. Normally, these such areas are not designed. What is happening is that OT is having an adjunct surgical ICU with all equipments ready over there. But carrying out a surgery at surgical ICU is very difficult. So we need to have some lobby or some space which is a safety place at that moment where we can take the patient and carry out the procedure for some time with the help of the oxygen cylinder if that much is the emergency. As Dr. P.P. Joshi sir has already said, when their care hospital emergency has happened in Nagpur, they have safely transported even the cardiac patients to the nearest hospital. So MOUs with the other hospitals, informing the other hospitals that we are bringing the incoming or the operating patients to the other hospital or shifting them requires a lot of important inputs from the one who is managing, that is the officer who is managing this type of crisis. So the communication to the other place is very important at this junction. So clinical staff will take over the clinical important steps inside the OT, but conducting it to the other area, the communication will be the key. And what important things happen nowadays in ICU when we shift the patient, all are the EMR. They are the electronic medical records. So we have the EMR system and we don't have the manual cards with us, the treatment cards with us. So sometimes we can make a rule that at least one printout of the patient's treatment can be taken in the ICU in the morning, even if we are putting the EMR records. So though we are going paperless, carrying a paper in these situations may be of help. So these certain inputs can be of help at the time when we are having a EMR records. Now the evacuation action card is this amount of step. As it has already been covered, we are going to skip this, that shut off walls, fire call point. The important point which we need to skip is stop high frequency nasal oxygen and nasal cannula if the patient is in ICU. So try to disconnect them. If it is possible, for the patient, we can take the risk of that patient to be coming off oxygen or minimize the oxygen to 21% FiO2, or we can take the patient on ambu venti. So this is another disconnection of this important high frequency oxygen cannula. This call is to be taken by the physician or the intensivist or the anesthetist who is there on the site. Now, whenever we are shifting the patient, has already been covered by doctors, the established patient in safe areas should be followed up for any harm that has happened because of the fire that has erupted. It may be a psychological trauma or it may be a physical trauma at that point. Evacuation boxes, I need to insist that evacuation boxes has been mentioned by everyone. The point I want to insist is the torch, the light, the emergency light. Every OT, according to protocol, have one emergency light. If the electricity system is disturbed, we have to keep one emergency light inside the OT. And in fire, this is to be carried with us in the evacuation box. There is a night, there is an absolute darkness around, and we need an emergency light to carry on the surgery or the critical steps. So emergency charge lights inside every OT is one of the important points for the OT safety protocol according to NABH. Still, it is important for our point of view also. So what NABH is following in their protocols, most of the safety protocols are coming to our help also for the fire. Fire triangle, so we can have to disconnect heat, O2 and fuel. This triangle has been mentioned by doctor previously. Now what are the specific measures we can use in operating theaters when using lasers or other potential fire hazards? Now laser is one of the points where the fire can be erupted inside the OT. And because we are considering about the OT, we are going to talk about this point, that fire within the operating theater represents a serious safety risk at the patient undergoing the surgery. So what is important is oxygen, ignition source and fuel is to be disrupted if we are using the laser surgery inside the OT. So what we can do, the risk of the fire in OR can be reduced by safe use of diathermy, safe use of lasers, and safe use of even fiber optic light sources, which are very, very frequently used in the difficult airway cases, for endoscopic procedures, for laparoscopic procedure. So igniting sources has to be properly covered. Their electrical wirings has to be very much cleared. And if at all the fire happens, the surgical drapes has to be, they are also filled with the oxygen. So what we have to think is that the cover of the plastic sheet which is kept over, it is just to take a care that it is not going to energize the particular area with the oxygen. So this, which can catch a fire and immediately catch hold of the patient in case of the emergency. So what I will insist upon is the diathermy, the lasers, the optic sources, and the last one, which is very commonly used, is alcohol-based cleaning solution, chlorhexidine. If you are using the chlorhexidine in an area, allow it to dry, drape the patient, allow it to dry, and then start the cautery when using it, so that the precautions can be taken that patient will not be catch fired with these type of induced methods by either the anesthetist or the surgeons, or if for that matter any staff member in the OT. Now what we can do, we can stop the laser diathermy, call for their help, then activate the fire alarm, fetch a carbon dioxide fire extinguisher, airway fire, stop ventilation of the patient, stop fresh gas flow, reduce the FiO2 to 0.21 or 21%, flood the airway with a sterile water or saline, remove the tracheal tube if it is needed. So this is if the patient has already catch fire and giving damage to the trachea. These all measures can be done. Non-airway fire, remove all drapes, burning material, flood fire with saline or saline soap gauze, use a carbon dioxide fire extinguisher. And consider the risk of the patient of inhalation injury with the potential lead for the intubation. Then step 6, if fire continues, consider operating the AVSU. We have already oxygen shut-off valve. For OTs, sometimes for the major, we can have 2 or 3 OTs where oxygen shut-off can be together. So if we have to take precaution that shutting off these 3 OTs to be intimated that fire is catching one, the other 2 can be taken care of. Lies with the anesthetic coordinator and operating OR who should have a time to evacuate within 30 minutes time. So this much time, some other OT can be used for the safety. The table can be removed, can be taken to the other OT. Evacuation aids I will not take because this has already been covered. Stretchers, sheets, mats, everything has been covered. Then the sheets and these diagrams we have already seen in the previous picture. The sketches, though they are not available to us directly. This is the National Disaster Office which have the sketcher. We are not habitual of using the sketcher. What is material is available, we should be habitual of using this. So their mock drills of putting the patient on a mat, putting the patient evacuation sheet, taking the evacuation box, these mock drills has to be repeatedly done in the hospital. Smoke hoods, I have already said that this is not available with us, but smoke hoods, it is just like a personal protection equipment, can't be used by everyone. COVID era has already given us a trial that how we are going to use the PPE, but PPE can be safe as well as it is unsafe, because sometimes the smoke will not allow us to see the whatever the guidelines, the cards, even sometimes the picture in front may not be clear. If there's a lot of smoke and you want to protect yourself with the PPE kit or the smoke hood. So smoke kit is not ideal, particularly in our inside area, to be used. This we have already covered. What is important for us is evacuation routes to be planned. That has been covered by Dr. previously. Equipment failures and the precautions in cases of electric fires. This has already been covered. And oxygen enrichment, what we can stop. HFNO, face mask, CPAP, whatever the oxygen, try to take it to minimum. Try to have less than 10, minimum 10 air exchanges, so that as Doctor already covered, the air exchanges not more than 10 air exchanges is to be allowed inside the OT, so that oxygen enrichment of the environment can be reduced. Now, what is a key? What is a key in on fire in any critical area is a communication. And communication can be taken care by the clinical coordinator as well as the management coordinator, the safety officer. And what we have to see from this, that evacuation coordinator will be in the center, so that he will be giving the input where the incident has happened. He is giving the input where what is going on in the field when we are shifting the patient, and the triage is happening as according to the protocol or not. So communication is the key for the transfer of all the OT patients to a safe area, all the ICU patients to the safe area. And communication can happen only when we are rehearsing it a number of times. Otherwise, even though we have an evacuation card in front of us, we could not even read a single thing at a time of emergency, at the time of anxiety, at the time of the panic. So panic is there for others. Panic is not there for the medical staff who is operating inside in the critical area. They have to remain calm and quiet. So take-home message will be need to be alert. If there's a fire, immediately communicate that so the manual call point, fire point is to be activated. Communicate with a code red. Be calm. Leads has to be pre-decided. Every hospital, whenever has a floor coordinator, have a lead to be in situ, so that who is the lead if this type of disaster is happening. So lead is to be pre-decided. Once lead is pre-decided, he has to take care of the gadgetry which is involved, which is evoking the fire in the area. It's not happening at frequent intervals, but the person who is there as a lead has to take a precaution to have an assessment. He has to decide the protocol of the hospital, follow the safety guidelines, the national guidelines, try to have their SOPs prepared, their hospital SOPs according to their setup, mock drills to be conducted, prepare physically and mentally both, perform well, and take actions immediately. Thank you. Stay alert, stay safe.
Thank you, ma'am. The session 2 is ended with this presentation. Now I would like to take the comments from the panel member, Shri Prashant Lonkar sir, fire advisor. Dr. Aradhana ma'am.
It's an excellent presentation. I must compliment for that. And the command you are having on the fire subject, as well as the clarity about the emergency preparedness plan, is excellent. I have one question for you. We have talked about the SOP and the procedure available, training, awareness, mock drill, firefighting system. But there is a requirement of the evacuation equipments also, like skate stretcher, evacuation chair, then horizontal lift and all. Whether your hospital is equipped, or you can tell in general also, what is the preparedness of the hospitals in that regards?
Nowadays, everyone is because of these fire safety protocols and guidelines, everyone is aware about the evacuation things that has to be needed, and evacuation boxes are very well ready. Evacuation, we have our hospital has evacuation lift, separate evacuation lift, fire lift, which is available with us. So apart from that, the stretchers and mats are there. But what I want to say is that the awareness among the staff still is not that much, because this is probably the beginning with this conference, we have also enlightened so many things, and we will take into consideration in coming days the more mock drills with this, and the awareness will be little bit required, but the gadgets are there. Gadgets are there, sir. Yes.
Okay, gadgets are sufficient.
Gadgets are there. Yes, yes.
Okay, thank you.
I would also like to congratulate for such an excellent talk. And not just this, even the previous lectures were very good in the sense the content that was presented, it reflected that how much the person actually knew, and when you know something, you will definitely try and implement in your hospital. A few things that I would like to add is, I was at Safdarjung Hospital. There we used to conduct routinely mock drills and training activities. What helped the most, it's a very big hospital. It's not like we did not have fire incidents. Being such an old hospital, it did keep happening. But after regular trainings, the training sessions we organized were in very small groups, and we always gave them hands-on training. So a person was very confident of using the equipment by themselves in case of fire. So mostly everything was handled initially only before you needed any help further. Second thing is the mock drills also, when you talk about it, should not just be a formality. एक mock drill document कर ली. It should be done in, for a big hospital, you have so many buildings. So you should design it in such a way that certain areas, mock drills are conducted area-wise. And when you do it, the people there should know what are their roles, who should handle the fire, who should take care of the patients, who is the leader. We were also trying to come up with some concepts such as fire marshal. So these are things which can be definitely implemented gradually, and the smaller size of training and mock drills will definitely help in a hospital because they bring about more awareness and more confidence in the staff. Thank you.
Very good afternoon to all of you. All our presentations are very nice, and it was enlightening what Professor Sontake told. They have, and Director Delhi Fire Service also was mentioning they have a good knowledge about the fire safety. So all compliments to the speaker. I would like to add one thing. Since we all are aware about this, we are all educating about the fire safety and norms and all those things. And we discussed about evacuation plan, mock drills, and what are the equipments available. They are all there in that place. What we found most of the time, it is there available. But the critical part of this evacuation or fire safety, that many times they are being ill maintained, or जो staff hai, they are ill trained. So my experience goes, I was actively participated in this COVID era, this COVID first and COVID second. I was with DRDO then. So we built many COVID hospitals, including in Delhi. We had 1,000 bedded makeshift arrangement hospital for COVID patients, and that to 500 was the ICU beds. Then we had in Jammu, Varanasi, Ahmedabad, Lucknow, Guwahati, Rishikesh. So, and many places we did that hospitals, and fire safety was our responsibility because I was working in this area from last 20 years. So I was one of the member in that committee. So what we did, what we decided, and what we could see, that we cannot afford to have any such accidents there. It is, you just cannot afford to have any accident. Can you imagine a makeshift arrangement where 1,000 bedded hospital and 500s are there in the ICU beds? So can you imagine if some mishappening is there? So what you will do? It is just, you cannot do whatever, unless until God grace you, you cannot do much in saving that life. So what we did, we hire people. In each shift, 3 shifts, we hire people. We made checklist for equipments, we made checklist for evacuation routes, we made checklist for training, we make checklists for electrical appliances, diesel generators, and all those things, all the electrical equipment. In fact, our man, they were instructed ki you have to inspect each and every conduits and all. So I can tell that there was not a single accident in all these DRDO hospitals, because it was a prestige issues, because it was been done by the Ministry of Defense then. And simultaneously, if you can recall, there were so many accidents in the country in other hospitals, but there was not a single accident in any of our DRDO hospitals. So it has what it happened because we continuously train what Dr. Atul Garg was mentioning. Training and checking equipments is very important. Rather than, but these are the most important things. So my only message in this forum that we should be proactive. We should work for prevention. We should not we should not imagine or we cannot afford to have any fire accident. We should prevention में हमारा ज़्यादा ध्यान होना चाहिए, or we should do all the efforts to prevent accidents, and there should not be single accidents. And it has been said कि जितना आप it has been Colonel may agree with me, Colonel Nikhil may agree with me कि the sweat you आपने जितना पसीना ground में बहाया उतना खून आपका बचेगा. So it is like that. So we should do these things and we'll get a great success. Thank you.
Thank you, sir. With this, we finish the first two technical sessions in the first half. Now we would like to resemble this token of appreciation for the eminent speakers. Now I would like to request all the panel members to come forward to present a moment to the eminent experts. Shri Prashant Lonkar sir, Atul Garg sir, Dr. A.R. Sontekke sir, and Dr. Aradhna ma'am. Now the joint collaboration in association with the All India Institute of Medical Sciences. The first, Dr. Sucheta Bhute ma'am, Surgical Intensive Care Unit. I would like to request her to give a, sir, director sir. Dr. Udit Narang, Medical Intensive Care Unit, AIMS Nagpur. Next, I would like to call Dr. Abhijit Chaudhary, Pediatric Intensive Care Unit. Next, I would like to call Dr. Nishant Banayak, NICU, AIMS Nagpur. Last but not least, Dr. Sarita Jogelkar ma'am from National Cancer Institute, Nagpur. Thank you. Thanks for the panel members. Now we go ahead with the session 3 and session 4. And we would like to continue with the Dr. A.R. Sontekke sir and Dr. Aradhna ma'am, Dr. Prashant Lonkar sir. And I would like to invite Shri Moreshwar Kudikilwar sir, Deputy Fire Advisor, to come on to the dais. Now for the session 3, the theme is evacuation plan for critical wards. Now I'd like to introduce the Mrs. Leena Boate, Quality Manager, Head, Lata Mangeshkar Hospital, and the Brother Robert K. Devanand, Clinical Health Educator, Lata Mangeshkar Hospital, Nagpur. I would like to invite them for the third session.
Thank you, sir, giving an opportunity to me. Thank you very much. This is the scenario of when fire outbreak. Today's my session is safe fire evacuation plan for critical wards, ICU, NICU and PICU. Already ma'am Suchita ma'am and all sir and ma'am are giving the lot of information about the safe evacuation plan, but I will give the generalized idea about the safe evacuation plan. When you prepare the safe evacuation plan, it's a very clear and concise. When you applicable in action in the critical units, fire evacuation plan is prepared according to standard of procedure and structure set. Why it's structure set? Because designed to ensure the shift and evacuate the patient when patient is very critical. It's include that clearly marked. Why is clearly marked? Except route are very clear and emergency exit and pathway are very clear, designated assemble point and instruction for individual follow. The plan according to priority and according to critical patient safety prepared and minimize the panicness and provide a guidance for assisting those without the special needs. Objective is that life safety. Sir already told me that nobody can add the life safety. Yeah, definitely. It's very important. While evacuation, life safety is very important. NICU, PICU are the admitted the vulnerable patient and so critical when the patient are moved all over, that time we need the special care. Efficient response. If team are ready, example firefighting team, admin team, rescue team. When you evacuate plan implemented in the practice, rescue team role is very important. Continuity of care. Already sir told that while critical patient transfer, that time we need the ventilator, we need the monitors, incubator. NICU baby are not say some words कि मुझे help चाहिए या मुझे shift करो. They can't able to shift. तो सभी vulnerable patient को अगर आपको shift करना है, तो with the emergency aids you will ready to transfer. Priority and asset protection, definitely. Life safety is very important, but important is that property and asset the protection. Compliance, already discussed that Suchita madam, compliance with regulation Yeah, definitely fire NOC is very important while install the fire equipment instrument. Now I discuss with you preparedness of safe fire evacuation plan in critical unit. जब भी आप कोई प्लान करते हो तो उसको एस्टैब्लिश करिए. आप अगर एस्टैब्लिश कर रहे हो तो प्रिपेयर द डायनेमिक टीम. हाउ? फायर फाइटिंग टीम assign the role, who one use the equipments, who one clear the pathway, who one giving the fire transport system facility, and readiness to first aider team also. First aider team means doctor, nurses, with all equipment they are support. एक बंदे से कोई काम नहीं होने वाला है, पूरी टीम की जरूरत है. जैसे विनायक सर ने ऑलरेडी डिस्कस किया है कि आप जब भी क्रिटिकल पेशेंट को इवैक्यूएट करते हो तो 4 लोगों की, एक अगर बच्चा अगर शिफ्ट कर रहे हैं तो 4 लोगों की जरूरत डेफिनेटली लगेंगी. आप जो भी डायनेमिक टीम बना रहे हो, असाइन द रोल्स एंड रिस्पॉन्सिबिलिटी. उस टाइम में जब भी आप, पैनिक टेस्ट तो रहता ही है और एक डर रहता है कि क्या होगा, पहले तो मेरी जान कैसे बचेंगी ये सोचते हैं सब, बट रोल असाइन अगर रहा तो डेफिनेटली वी आर doing 100 giving the 100% efforts and save the patient's life. Patient priority already discussed. Stable patient are shipped immediately and after critical patient are shifting in safe zone. Emergency equipment readiness definitely होना चाहिए. Ventilator, monitors, incubator, etc. Mock drill. It's a short words, पर उसमें जो मीनिंग, जैसे रिहर्सल करना बहुत जरूरी रहता है ना, पिक्चर में 1000 टेक लेता है एक्टर. रिहर्सल अगर नहीं किया ना तो ये प्लान, ये कितना भी अपन ने पढ़ लिया थेराटिकली और वी कांट इम्प्लीमेंट इन द प्रैक्टिस. तो जो भी आप प्रिपेयर कर रहे हो थेराटिकली, यू कोरिलेट द प्लान इन क्लिनिकल साइट, ताकि रिहर्सल जब वक्त आता है जेन्युइनली एप्लीकेबल करने का, तब आप उसको अच्छे से कर पाए. दिस इज द सिनेरियो. गुड टीम फॉर्म, collaboration, communication, and good taking the efforts while shifting evacuation the patient, and collaboration with the team, rescue team. Safe zone. जब भी आप पेशेंट को इवैक्यूएट करते हो तो आपने पहले ही रीलोकेट टेम्पररी एरिया, रीलोकेट आइडेंटिफाई करना है. जब भी आप पेशेंट को इवैक्यूएट करते हो तो आपको मालूम होना चाहिए कि उसको क्या लगने वाला है. क्रिटिकल पेशेंट मतलब वल्नरेबल पेशेंट, NICU का न्यूबॉर्न बेबी या क्रिटिकल पेशेंट जो भी आप शिफ्ट कर रहे हो, ऑक्सीजन, मेडिकल सप्लाई, एंड सब लोगों ने अभी सुना है कि स्विच ऑफ करना है ना, तो उसके लिए इमरजेंसी लाइटिंग भी लग सकती है. वर्टिकल इवैक्यूएशन एंड हॉरिजॉन्टल इवैक्यूएशन आई स्किप बिकॉज ऑलरेडी डिस्कस दैट थिंग्स. स्टाफ कोऑर्डिनेशन. अगर नर्स इज नॉट रेडी टू इवैक्यूएट द पेशेंट एंड व्हाट इज हर रोल, ये अगर उसको मालूम ही नहीं तो क्या करेंगी वो तो खुद ही डर जाएंगी. जैसे अभी रिसेंटली एक इंसिडेंट हुआ है उत्तर प्रदेश में. स्टाफ कोऑर्डिनेशन, ट्रांसपोर्ट फैसिलिटी और मॉनिटर वाइटल्स ऑफ इक्विपमेंट आपको मालूम होनी चाहिए. सबसे इंपॉर्टेंट क्या रहता है? कम्युनिकेशन प्रोसेस. इट्स वेरी क्लियर. ऐसा नहीं कि मैंने बोल दिया इंटरकॉम में हाँ आग लगी है, इसका इफेक्ट होगा क्या? लाउडली स्पीक आउट, फायर फायर फायर, somebody are help. इन द नाइट, इन द मॉर्निंग, इन द इवनिंग, कभी भी हो सकता है इंसिडेंट, तो आपको लाउडली स्पीक आउट करना है. पब्लिक अनाउंसमेंट सिस्टम होंगी, उसका यूटिलाइज करना है. इंटरकॉम वर्किंग है कि नहीं है वो मालूम होना चाहिए. अलर्ट, अलार्म, एक्सेस सबको मालूम होना चाहिए क्या प्रोटोकॉल है. और ट्रिगर द फायर अलार्म. सिचुएशन और नीड ऑफ द पेशेंट. टेक द 2 minutes. Can I take? Yeah, thank you. Fire process already we will giving the demo and how to implement that process in the clinical area with Robert sir. दिस इज द सिंपल प्रोटोकॉल. फायर अलार्म साउंड होना चाहिए, एक्टिवेट प्लान होना चाहिए. अगर एनआईसीयू में आग लगी है या नियर बाय एनआईसीयू लगी है, आपने उसको आइडेंटिफाई करना है. प्रायोरिटी अकॉर्डिंग आई ऑलरेडी टोल्ड दैट. एंड शिफ्ट द पेशेंट. अगर दोनों प्राइमरी और सेकेंडरी एग्जिट अगर ब्लॉक हो गया है तो आपको अल्टरनेट एग्जिट का यूज करना है. एक्सटर्नल इवैक्यूएशन ऑलरेडी नाइट सर गिविंग द इंफॉर्मेशन. अगर पूरा हॉस्पिटल मेजर फायर आउटब्रेक हुआ है तो आपको अनदर इंस्टीट्यूट में भी पेशेंट को ट्रांसफर करना पड़ सकता है. असेंबल पॉइंट में कलेक्ट करना है, अकाउंटेबल रहना है, सर्च करना है अगर एक आधा पेशेंट मिसिंग है तो, और उसको सेव करना है. इन्फॉर्म इमरजेंसी रिस्पॉन्डर एंड एडमिनिस्ट्रेशन. This is the advance here. If give the 2 minutes, definitely I will discuss that point. Scenario देख के आपको क्या लग रहा है? कोई बचा होगा? नहीं, क्योंकि ऐसा लग रहा है ना सिनेरियो देख के. But definitely ambulance driver are taking the efforts and save the pregnant women. Next scenario is that झांसी. सिनेरियो देख के आपको लग रहा है कि क्या सिनेरियो होगा और क्या मेजर फायर आउटब्रेक हुआ होगा वहाँ पे. तो ये सब 2 केसेस है. सबसे इम्पोर्टेंट रहता है जो भी हुआ उसका कॉज फाइंड आउट. व्हाट, वेयर, व्हेन, बाय, हाउ. पुअर कम्युनिकेशन, ट्रेनिंग, लैक ऑफ कोऑर्डिनेशन, टीम कोऑर्डिनेशन बराबर नहीं है, अवेयरनेस नहीं है, प्लान नहीं है, प्लान जो प्रिपेयर किया है उसका भी अवेयरनेस नहीं है, नॉलेज नहीं है, और फायर फाइटिंग सिस्टम जो लगाया है इक्विपमेंट वो वर्किंग नहीं है. तो ये सब, तो इसके लिए करेक्टिव एक्शन अपने को यही लेना है कि रिटेन करना है, रिहर्सल बार बार करना है. एक बार सीखने से नहीं आ रहा है तो बार बार करिए, रिवाइज करिए. जो भी आप प्लान प्रिपेयर कर रहे हो उसको रिवाइज करिए, और लेसन प्लान जैसा आपको उसको लर्न करना है और बाकायदा याद रखना है. कम्युनिकेशन प्रॉपर होना चाहिए. सबमिट द रिपोर्ट इंसिडेंट फायर का और प्रिवेंटिव मेजर. डेफिनेटली अकॉर्डिंग दैट करेक्टिव मेजर से ही आपको करना पड़ेगा. बट ऑडिट इज वेरी, इंटरनल ऑडिट तो हमेशा होता है पर एक्सटर्नल ऑडिट इज मैंडेटरी. दिस इज द वन ऑफ द सैंपल ऑफ एनआईसीयू पीआईसीयू सेफ फायर इवैक्यूएशन प्लान. आप लोग देख रहे हैं कि इट्स इज द इवैक्यूएशन प्लान. ये अप्लीकेबल करना चाहिए, सबको मालूम होना चाहिए कहाँ आप खड़े हो, है ना, और लिफ्ट यूज नहीं करना है. थैंक यू वेरी मच.
Good evening, all of you. Good evening, sir, and good evening, ma'am. फायर सेफ इवैक्यूएशन प्लान प्रोसेस बिल्कुल शॉर्ट में बताऊंगा. यहाँ पे बहुत सारे स्टाफ नर्सेस हैं, नर्सिंग फील्ड से आए हैं, और उनको इमरजेंसी में जैसे कि आईसीयू में है, एनआईसीयू में, पीबीयू में अगर फायर हो गया है, हमारा प्लानिंग कैसा होना चाहिए और हमारा प्रोसेस कैसा होना चाहिए, बिल्कुल शॉर्ट में मैं बताऊंगा. हॉस्पिटल इवैक्यूएशन प्लानिंग, फायर प्रोटोकॉल, एसओपी के बारे में सबको हमें पता होना चाहिए कि फायर एसओपी हमारे हॉस्पिटल में फायर एसओपी किस तरह से करना है. अवेयरनेस अबाउट सेफ फायर इवैक्यूएशन प्लान एंड हाउ टू इम्प्लीमेंट इन क्रिटिकल केयर यूनिट. कोड रेड फायर इमरजेंसी नॉलेज ऑफ स्टैंडर्ड ऑपरेशन प्रोटोकॉल फॉर एससीपी, हेल्थ केयर प्रोवाइडर, मेडिकल nursing staff and housekeeping staff. Fire alarm. Safe evacuation plan. Fire alarm. Smoke detector activate होएगा और सेफ डिटेक्टर ऑफ एक्टिवेट होने से पहले हमें क्या करना है, उसे हमें जो आईसीयू में, सपोज अगर आईसीयू में फायर हो गया है तो हमें वो पेशेंट को हमने सेफ जोन में लेके आना है, एंड वहाँ सेफ जोन में लेके आने तक हमें वहाँ के जो ऑक्सीजन सप्लाई है और इलेक्ट्रिसिटी है, अगर ज़्यादा ही अगर आग बढ़ गई है तो उसे हमें शट डाउन करना है। और इन कंट्रोल पैनल डिस्प्ले लोकेशन दिखाई देगा उन्हें, तब हमें हमारा ये रहेगा, वो जो ऑन ड्यूटी स्टाफ रहेगी उन्हें एक्टिवेट करना है कोड रेड, एक्टिवेट कोड रेड, एक्टिवेट कोड रेड अनाउंस करना है हमें पीए सिस्टम से 3 टाइम, जैसे कि कोड रेड इन आईसीयू सेकेंड फ्लोर, कोड रेड इन आईसीयू सेकेंड फ्लोर, कोड रेड इन आईसीयू सेकेंड फ्लोर with precise location, clear pathway. इसके route should be kept clear, all obstruction, कोई obstruction नहीं होना चाहिए। जब भी हमें पेशेंट को ट्रांसफर करते हैं तो उस समय में पेशेंट को साइकोलॉजिकल सपोर्ट देना बहुत जरूरी है, क्योंकि कोड रेड अनाउंस हो गया है, सबको पता है कि कहीं आग लग गई है, सब लोग दौड़ेंगे आईसीयू के तरफ में और वहां पे एक ऑब्स्ट्रक्शन तैयार हो जाएगा, वो हमें नहीं होने देना है और वहां से हमें पेशेंट को आउट करना है। एग्जिट, एग्जिट सब हॉस्पिटल में एग्जिट के बोर्ड लगे होते हैं, उस तरह से एग्जिट देखना है, क्योंकि वहां पे लाइट्स नहीं रहेंगे, इसके लिए हमें इमरजेंसी लाइट का यूज करना है। और उसके बाद जो साइनेजेस लगे हैं, येलो और ग्रीन कलर के जो साइनेजेस होते हैं, उसको देख के हमें वहां पे वहां पे ट्रांसपोर्ट करना है। यूज फायर फाइटिंग इक्विपमेंट, फायर फाइटिंग इक्विपमेंट जैसे कि हर स्टाफ नर्सेस को और हाउसकीपिंग स्टाफ को और इवन आरएमओ को हम पता होना चाहिए कि फायर इंस्टिंग्विशर जैसे हॉस्पिटल में जो होता है एबीसी फायर इंस्टिंग्विशर, और वो हमें किस तरह से यूज करना है, जैसे कि रेस एंड पास। एंड उसके बाद जो इक्विपमेंट में आता है फायर स्प्रिंकलर एंड हाइड्रेंट सिस्टम। सेफ जोन आइडेंटिफाई करना है हमें, रिफ्यूज एरिया वहां पे लेके जाना है और ट्रांसपोर्ट करना है, और असेंबल एरिया तक लेके जाने के लिए हमें सेफ मैनर में पेशेंट को ट्रांसपोर्ट करना है। एंड असेंबल पॉइंट, असेंबल पॉइंट में सबको कंफर्म हमें करना है कि सब असेंबल पॉइंट, हॉस्पिटल का असेंबल पॉइंट कहाँ पे है, सभी स्टाफ को उसके बारे में हम पता होना चाहिए, और ऑन ड्यूटी स्टाफ को, और उसके लिए पेशेंट को, रिलेटिव को, और जो भी स्टाफ है उनको हमें बताना है, और वो जो ऑन ड्यूटी स्टाफ है वो बताएगी कि हमारा असेंबल पॉइंट कहाँ पे है, और उस तरह से हम पेशेंट को ट्रांसफर करेंगे। एंड उसके लिए हेड काउंटिंग हो जाएगा। हेड काउंटिंग के लिए सब क्लियर हो गए, पेशेंट को हमने शिफ्ट किया है, और सभी वहाँ यूनिट के सभी स्टाफ वहाँ अवेलेबल है। तो फायर ऑफिसर का, ये फायर ऑफिसर जो होते हैं हॉस्पिटल में, एक पोस्ट होती है उसमें फायर ऑफिसर काउंट करेंगे और वो डीएक्टिवेट करेंगे कोड रेड, और पेशेंट काउंट करेंगे, जैसे कि वहाँ के पेशेंट और स्टाफ, नर्सिंग स्टाफ, हाउसकीपिंग स्टाफ और मेडिकल स्टाफ, एंड डीएक्टिवेट करेंगे कोड रेड। इनफॉर्म अथॉरिटी, अगर आग कंट्रोल में नहीं हो रही है, इसके लिए हमें 101 डायल करना है, और एनएमसी में बताना है, और पुलिस डिपार्टमेंट में भी बताना है, और उसमें हमारा नाम और लोकेशन बता के, और पुलिस और एनएमसी में हमें बताना है 101 डायल करके। एंड रिपोर्ट, टाइम टू टाइम रिपोर्ट, हमें जो भी फायर हो गया है हमें टाइम टू टाइम रिपोर्ट करना है, जैसा कि फायर डेट एंड टाइम, प्लेस, किसी को हार्म अगर हो गया है और कोई इंज्योर्ड हो गया है लेके जाते हुए, और उसका सभी रिपोर्ट हमें तैयार करना है और सबमिट करना है रिपोर्ट। एंड डीब्रीफ, Find out fire incident event and checklist. ये हमें डीब्रीफ करना है और इस तरह से हमारा ये प्रोसेस, हमारे नर्सिंग स्टाफ ये पूरे ऑल ट्रेंड होते हैं. जैसे कोई भी हॉस्पिटल में जो फायर इमरजेंसी कोड रेड अगर होता है तो सभी स्टाफ को इसके बारे में नॉलेज होता है. इसके लिए हमें अवेयरनेस प्रोग्राम और डेली मंथली मॉक ड्रिल और जो वीकली जो ट्रेनिंग्स और इसके जो प्रोसीजर वगैरह होता है इसके बारे में सबको पता होने के लिए हमें इस तरह से फायर प्रोसेस होना चाहिए. एंड ट्रांसपोर्ट करने के लिए अभी सबने सर लोग ने अभी हमें बताया है कि किस तरह से हमें ट्रांसपोर्टेशन करना है. जैसे कि स्टाफ और हाउसकीपिंग स्टाफ किस तरह से पेशेंट को ट्रांसपोर्ट करना है डेंजर जोन से सेफ जोन असेंबल पॉइंट तक लेके जाने के लिए, इस तरह से हमें पेशेंट को ट्रांसपोर्ट करना है. और ट्रांसपोर्टेशन के लिए हमें जो यूज होता है उस तरह से क्रच मेथड है, फायर फाइटिंग प्रोसीजर है ट्रांसपोर्टेशन के लिए, और यूसेस ऐसे चेयर हमें इस तरह से यूज करना है. एंड थैंक यू.
Thank you, ma'am and sir with the team. Last presentation of today's session, preparation of the patients with the Dr. Mayank Jaswal, GMC, Government Medical College, Nagpur.
Good afternoon, all the dignitaries present on the dais. I would like to first thank the Joint Director of NFSC to invite doctors here in this conference, as we both share the common motto, that is, we serve to save. So today I am going to present few slides on the topic preparation of patients for safe evacuation. Although many of the points are being covered previously by my fellow speakers, so I will cover the topic very crisp and shortly. So this slide covers most of the causes of the hospital fire. The most important among these is the cooking equipments, accounting for near about 50%. And the second most common is the trash and debris. And third most common are the electrical wiring. Now, this is the topic which is not discussed here, the classes of fire. There are 5 classes of fire, divided A, B, C, D and E classes. The type A, which is due to the use of ordinary combustible, that is wood, paper, trash, rubber, etc. Type B fire, which is due to the combustible liquids and gases. Type C fire, which is due to electrical equipments. Type D, which is due to the heavy metals. And type K, which is the most common due to cooking equipment. Now these 4 are the pillars of hospital safety: the prevention, suppression, evacuation and the evacuation training drills. The point 3, that is evacuation, this is the last mile resort which is to be adopted when the pillar 1 and pillar 2 have failed. Now coming on to prevention. The prevention comprises of few salient points: the planning consideration for new and existing hospitals, construction and design consideration, existing facilities, number of floors and the egress route. So for hospital safety, the planning begins when the hospital is not even built. When a hospital is planned, there is the design which comprises of the number of floors, the horizontal and the width of the hospital. So for fire safety, it is advisable that the number of floors should be kept to the minimum, and if there is enough land area, we should expand the hospital horizontally, just because in case of any emergency, maximum number of patients can be evacuated in a short number of time. And for the existing hospitals which are built, there should be a facility of retrofitting. And regarding the egress, there should be at least 2 egress routes for each and every floor. Now coming on to the suppression consists of the alarm system, smoke and heat detectors, fire suppression in the form of extinguishers, water sprinkler, mist sprinkler systems, water hose reels and smoke extractor. So this is the diagram which is showing different hospital safety equipment which are pre-installed at the time of construction. So this has already been discussed, the hospital safety guide, what is to be done in the case of fire, which is can be remembered by the mnemonic of RACE, that is to rescue the person who is nearby to the fire, to raise the fire alarm, to contain the fire by closing the doors and windows, and to extinguish the fire by using extinguishers. And if it is not possible to contain the fire, then we should close the door and run away. And the guide to use the fire extinguisher can be learned by the mnemonic of PASS, which is the pull, the lever, aim, squeeze and sweep. So this is the diagram showing the hospital safety measures which has already been discussed. And this is the emergency codes for the hospital. The code red, which is the worst nightmare of a hospital safety officer. Now this is the fire safety symbols which guide us in case of any emergency. This is the continuation of the same, and here we can see in the green the assembly point which is shown here. This is the point where all of us will gather in case of any hospital contingency. Now coming on to the evacuation. Evacuation is the crucial component of the aim to save the life, and it is also the last mile resort which is to be done after the prevention and suppression have been failed. Now a comprehensive evacuation plan needs to be in the place to rescue the personnel, which has already been discussed in this session. Now coming on to the types of evacuation, it is divided on the basis of the time that we get for evacuation, and it is divided in the following headings: immediate, rapid, gradual and prepare only. Now coming on to the instructions, the prepare only evacuation instruction. So if you hear a fire alarm or see flashing lights in a hospital, you must ensure that the corridors are clear to allow movement of the patients and equipment. Locate and secure patients' medical records and medical supplies. Ready evacuation transport equipment such as wheelchairs, blankets. Set in motion a system to move people to a designated assembly point, and to await for further instruction. Do not evacuate until given the authorization. Now this has been already discussed, the types of movement, the horizontal, vertical and the shelter in place. So horizontal is the most preferred, but one thing about the vertical movement is, vertical movement should be tried in a downward direction. That means if a fire is at the second floor, we must try to shift the patients to the first floor rather than to the third floor. Now coming on to the evacuation routes. So all the hospital staff and the security personnel, including doctors and nurses, should know regarding the evacuation routes present in the hospital, and specifically assigned staff members that are referred to as wardens or health and safety officer should then direct the patients and visitors to for calmly evacuation. Evacuation planning must take into consideration all the spaces around the hospital compound. Now the levels of evacuation is divided into two types, the complete and the partial evacuation. And the situation which may warrant evacuation in cases of hospital, they are fire, smoke and toxic fumes, structural damage to the facility, potential exposure to hazardous materials, terrorism or violent armed visitors, and a credible bomb threat. Now this is not discussed in the session yet. The patient prioritization evacuation models, and these are divided into three types: the geographic, the resource model and the equity model. And here in the image you can see a evacuation plan. These plans should be placed at each and every floor in the hospital so that the person which is stuck up at any floor should get to know about the egress routes, the most safest routes, and the position of the fire extinguishers that are present at that floor. Now coming to geographic model, it is usually applied in cases of gradual evacuation where there is sufficient time to evacuate, for example in cases of floods. So this model focuses on evacuation of areas at greatest risk within the hospital or designates individual care unit to evacuate sequentially. The pros of this model is it allows a partial evacuation that will not disrupt the entire hospital. Second, it will allow units to stay together throughout the evacuation process. But the cons is it requires a considerable amount of time. The second model, a resource model. This model focuses on utilizing the resources in the most efficient way, and patient prioritization is directly linked to the resource availability. The pros is the efficient use of resource, effectively streamlines the evacuation process in a top-down or bottom-up manner, and the con is it requires a real-time planning and logistical management to best allocate the resources. Now the equity model. This model attempts to account for patients' mental and physical condition. The most medically fragile patient may be evacuated last to ensure that they are not removed from the ventilators and other life support equipment. The pros is it mobilizes the most mobile patient, and the ultimate goal of this evacuation process is to do greatest good for the greatest number of the patient. For example, if a situation arises in a hospital where we have to triage the patient, or we are not able to save each and every person, then we should go for the maximum number possible and do greatest good for the greatest number of patients. The con is that it does not account for allocation of scarce resources, which would lead to situation in which ICU patients would have to wait longer periods of time. So this has already been discussed, the priority ratings for immediate evacuation of the patients. So the last priority is it has been given to the patient who are in the operating room, and as the previous speaker has highlighted the point that any surgery should have been completed to a safety point, after which the patient can be mobilized. So these are the ways in which the patient can be mobilized. Stretcher and two personals are there to mobilize the bedridden patient, and the persons who can take wheelchair on their own, they can be mobilized solely. Regarding the equipment that are used for evacuation, we have the blankets, wheelchair, beds, backboard, sked stretchers. So we must ensure that enough number has been there with the hospital, so that if in any case any contingency arise, we have enough stock of them. So this is the picture of a fire blanket. This is the gurneys and the litters which can be used in emergency cases. And this is the sked stretcher, which usually the hospital doesn't have this. And these are brought by the firefighters and the NDRF team. This is the bed which are used in the ICU, and it can be mobilized. So the doors and the corridors should have enough width so that these bed can pass through. Now coming on evacuation of the patients with special needs. So evacuation plan for OT patients. So this is the first response program for staff in ICU and OT. So once the smoke is detected, following actions need to be taken: to extinguish the fire with the help of fire extinguisher at the source, to remove all the inflammable liquids from near the source of fire. For example, OT uses some anesthetic gases, for example cyclopropane, ether and nitrous oxide, which are very flammable and should be kept away from the fire. So to discontinue air conditioning gases until the fire is extinguished, discontinue the air conditioning system and activate the ventilation system if available. So once the smoke is completely evacuated, to assess the general condition of the patient and initiate the treatment plan accordingly. If the smoke or fire is out of control, then as per direction of the command center, the process of evacuation can be initiated. Now, a specific evacuation plan for ICU patient. These patients are also not capable of self-preservation and need assistance for evacuation along with life care equipments like ventilator. Now, medical care and equipment needs. Patient may require specific life support equipment, example ventilators, that should accompany them when they evacuate. So this is the management of fire in NICU, which has already been covered. Now coming on to special hazards and concern. So there are few specific hazards like oxygen. So procedures must be in place of turning off the oxygen as it can act as fuel for combustion and aggravate the fire. The smokes and fumes which can have their deleterious impact on the life and health of the patient. So effective mechanism should be there like smoke extractors which can be used. Electric equipments. So we have to unplug the electrical equipment to contain the fire. And water which can also serve to increase the fire and can damage the medical equipments while transport. Now the most important thing, the tracking of the patient. So we must track the patient from the point where we are, taking the patient out from the wards or ICU, and we have to track the patient till the assembly point, so that each and every patient can be rescued properly. So there should be a appropriate head count at the assembly point, and we should also take the medical records of the patient, so that if the patient is getting shifted to any another hospital, the treating physician can know about the current condition and what the treatment the patient is getting at the previous hospital. So patient status and location, current location and their destination must be determined by the hospital incident commander. So this is the staff assignment. In case of any emergency, all the persons will come into action. This consists of evacuation warden, transport leaders, patient tracking supervisors, medical wardens, triage leader, transport leaders, etc. So this has already been covered. The hospital incident command system, which is a two-way system, and it's a measure of communication also. So now coming on to the process overview. When the fire alarm is raised, so we have to investigate that whether it is a false alarm or we have to quantify the magnitude of the problem, and then we have to the hospital incident commander then identifies the type of threat, and it will put into action the evacuation coordinator and the staff assignment, which will then prioritize the patient, and then they will track the patient to their assembly point. So if in any case the contingency arises, the most important thing is to stay calm and then take action. And the most important thing which everybody forgets is the mock drills, which is the practice makes the man perfect. So if we don't practice, then there is no meaning of putting lakhs and crores of equipments, fire equipments in the hospital. So in the last, I just want to tell कि तैयारी इतनी मुकम्मल हो कि जब वो घड़ी आए तो हम अपना सर्वश्रेष्ठ दे सकें ताकि हर एक मासूम जान को बचाया जा सके. थैंक यू.
Thank you, sir. Now we would like to ask the comments from the panel members. Sir.
तीनों प्रेजेंटेशन काफ़ी क्रिप्स और टू द पॉइंट थे. मोस्ट ऑफ द स्लाइड्स जो है प्रीवियस स्पीकर के स्लाइड्स में से जो कंटेंट था वो ऑलमोस्ट सिमिलर लग रहा था, लेकिन आपने उसको बड़ी स्मार्ट तरीके से जितना वहाँ से लेना है उतना लिया और बाकी अपना डालने की कोशिश की. और सबसे अच्छी बात है कि मैडम स्पीकर और उनके बाद वाले जो सर स्पीकर थे उनका जो मैंने देखा एक प्रैक्टिकल अप्रोच था, और जैसे क्लासरूम में बच्चों को पढ़ाया जाता है उस तरीके से इस थॉट को वहाँ तक पहुँचाने की कोशिश की कि इस चीज़ों को प्रैक्टिकली और जब ज़रूरत होती है तो किताबों में लिखा हुआ ज्ञान और उस ज्ञान को जब हम धरातल में लाते हैं तो उसको किस तरीके से लाना होता है, और लाते समय एक ही चीज़ काम में आती है, प्रैक्टिस प्रैक्टिस प्रैक्टिस। तो ये जो मैसेज आप लोगों ने अपनी इन तीनों स्पीकर ने अपने प्रेजेंटेशन में देने की कोशिश की है, वो मुझे लगता है इस सेशन का टेक अवे रहा। थैंक यू वेरी मच।
Dr. Mayank has given a very precise presentation on the safety evacuation measures. It was quite practical. Thank you very much.
Thank you very much. All the presentation was very practical and to the point. What is required and what need to be done has been very nicely presented. So I have already mentioned my thoughts in earlier session, but to add to it, hospitals, they are more the most critical occupancy whatever we are dealing with is the hospitals, because we have so much of crowd with them, with their critically ill patients, their relatives, and they are in stressed, living in a stressed environment. So if you happens to see that AMRI fire incidents in Kolkata, which earlier Dr. Joshi was mentioning, so we had so many casualties there, touching 200 casualties. And if you see and if you go through that case study, could it been avoided? Yes, it could very well been avoided. And it is not something like very rocket science or a heart surgery on neurosurgery type of things. It is very easy, and only thing is that key to fire safety, I'm in this profession from last so many years, so I can say the key to success is awareness. अगर आप जरा भी aware है इस subject के बारे में, if you are aware कि fire safety is important, then these things will never happen. And definitely you will give priority, or definitely your top management, your bosses gives due care to it. Mock drill will serve purpose. How it serve purpose? Because it gives a message to entire hospital staff and top management. Yes, fire safety is important, and that is how they got in picture. And because if you happens to visit many of the hospitals, you will find many of the staircases, they are blocked. कहीं अलमारी रखी है, कभी कुछ रखा है, कभी कुछ रखा है, because their priorities are different, because they are dealing with life and death. So definitely those are the important issues there. They have operations are there and all those things are there. So definitely what I meant to say, if you can pass this message, so you can have a volunteers on each floor. हर फ्लोर पे आपका एक फायर सेफ्टी का वॉलंटियर होना चाहिए. It may not be able to have a separate dedicated person. Of course, एक separate fire officer वहाँ पे designate होना ही चाहिए. But apart from that, if it is not possible, because some doctor was mentioning, GMC doctor, this medical superintendent, he was mentioning, we want to hire such people, but we are not able to do, because it's very difficult to hire people in government setups. So at least we can make our wardens or the staff who can be given additional responsibility, and he should be with the additional responsibility, he should be also awarded or something, he should be recognized. And that is how the importance of fire safety will increase in hospitals. If you give importance to fire safety, it is not just a matter of workshop or something like that. If you take it, it is one of the very important factor. Unless and until you have all the coordinates with you, you cannot achieve success. So it is like that. It is very important. First of all, this message goes to the top management, and we should what all the presentations are there. If you can take away this presentation and we can have volunteers on all the floors, then definitely things will improve. And definitely the day will not come, then we will not have any accidents like baby care centers or merit fire or whatever the fire are happening, AMRI fire, or so many fires are happening. So we will not have such type of incidents in our country. So thank you very much for these nice presentations. And
thank you, panelists. And really, the presentations were excellent. I would like to mention two things here. One is we are doing the rehearsal practice of the mock drill regularly, but that is not actual situation when there is a smoke comes. But as a profession by doctor, you are doing some simulation for the anesthesia as well as some surgery also. That kind of simulation we are going to arrange here in NFSC in very soon. There will be the simulator for the hospital, and the real smoke will be generated along with the patient and all, and then we will conduct that kind of drill here. So that will be the good opportunity for country also, nowhere it is available right now. And second thing, the presentation was excellent, as madam also mentioned. My one small query or question to the Dr. Mayank. You mentioned about the one of the hazard as a oxygen. Oxygen is really when it's more than 23.5%, that's called oxygen enrichment environment. And that is really dangerous. In normal case, when the things doesn't catch fire, that burns vigorously. And the spark which is not harmful, that is very dangerous in case of the oxygen enrichment environment. And it has been observed in the many fire investigation that the area was enriched with the oxygen. That's why fire propagated fast, fire started immediately. So that is the outcomes and the findings of the many fire investigation. My question is, or I would like to know from you, to know this, whether the environment really oxygen enriched or not, because you are handling the cylinders, oxygen sets there. Do you have any fixed monitor for that? Because nobody is thinking about this, because in industry normally we are concerned about the poisonous gases. But as far as the oxygen is concerned, we do have this kind of accident, fire incident, where we had a fatality also. But as far as the hospital environment is concerned, that is the only way to know the oxygen has enriched or has more in the environment. So you have identified that hazard, but do you think to monitor that, whether fixed monitor is required for that or not?
Yes, sir. Fixed monitors are required for this, but till this is not available in the hospital setup, the only thing that is available that almost previous speakers have mentioned regarding to shut down the oxygen valve. But it is a two-way sword. We can have deleterious complications due to that also, that during the transport time we can also lose our patient. But this is also necessary in this setup, as ICUs are oxygen concentrated places, and for anything that is combustible, the essential requirement is oxygen. So till date, there is no monitor how we can measure this saturation or the amount of oxygen which is present here. So we will hope that it will come sooner future.
Just for sake of my understanding and information, Dr. Jeswani, I like to know, in one of your slides, you have given that very good statistical pie diagram. And you mentioned almost more than 50% fire cause because of cooking appliances or cooking activities. So that statistics or that data being fetched from some any journal or some the source of that data?
Yes, sir. The data is taken from the WHO and Pan American Health Organization. There is a joint collaboration, and they have issued the guidelines where they have mentioned this pie chart, and the most important cause, which is the amounting to maximum chunk of fires, is the hospital equipments, the cooking equipments that is present in the kitchen.
Source is WHO.
WHO and Pan American Health Organization.
बस just for sake of वो कि आप अगले बार से जो है ना source लिख दिया करिए नीचे.
Okay.
That gets validate the data. Basically, data nowadays is very important.
Okay.
Sir, actually, I'm into hospital engineering from last 20 years. Earlier, I was working with Vedanta Medical. Earlier, I was working with Vedanta Medical Research Foundation. It is situated at Naya Raipur. So we have installed integrated building management system, which was having a sensors of O2 and CO2, and we have installed it in the ICU and OT. So whenever there is a permissible limit cross of CO2 or O2, we were having a monitoring system which were coupled with the fire dampers and the fire alarming system. So it was like one of the monitoring device which can be incorporated in the modern hospital right now.
Thank you, sir. Thanks for all the presentations. Now, I would like to request the panel members to come forward to offer a mementos to the distinguished speakers. Mrs. Reena Bote, Quality Manager, Head, Lata Mangeshkar Hospital, Nagpur. Brother Robert. I'd like to request Brother Robert K. Devanand, Clinical Health Educator, Lata Mangeshkar Hospital, Nagpur. Now I'd like to request Dr. Mayank Jeshwani, Government Medical College, Nagpur. Thank you, sir. Thank you all the panelist members for gracing these occasions and insightful suggestions to the audience. Now, I would like to request Dr. A.R. Sondeke sir, Professor, National Fire Service College, to give a vote of thanks and request for the concluding the program.
Thank you, Dr. Gautam. Now we come to the end of this workshop now. So it's my privilege to express the vote of thanks to the inaugural session first, the all dignitaries present there. And for the foremost, I would like to express my sincere thanks to the, Sri Vivek Srivastav, IPS, Director General, Civil Fire Service, Civil Defense and Home Guard, Prashant, Dr. Prashant Joshi, ED AIMS, Dr. Gawande, Dr. Shevalkar, and all the speakers. They have taken the session to that extent, and we were not expecting this much elaborative and the informative session would be. But objective of the session was to make the preparedness to handle the patient before the fire brigade comes. So in that perspective, I want some give some feedback. There we want some more information from your side technically, how you manage the patient there. Otherwise, I'm personally very happy having their interest and the knowledge about the information about the fire system and the drills you are having. I also express my sincere thanks to the all speakers, Sri Atul Garg sir, Director Delhi Fire Service, the special invitees, Rajesh Pawar sir, President IFE, A.K. Singh sir from IIC, and all the faculty members, all the NFSC staff who are working from last 1 week to make this program successful. I also express my sincere thanks to all the managements of the Lata Mangeshkar Hospital, AIMS Nagpur, GMC Nagpur, Cancer Hospital, and all students and participants who have given their time for this function. Thank you.
Thank you, sir. With this, we conclude all the proceedings of this workshop.